Oculoplastic Surgery. My main office is based in Wayne, and I'm also affiliated with Center City Dermatology. I see patients there 1 day a week. With my emerging practice, I've become an established local facial and jawline contouring specialist, attracting patients both regionally as well as out of state for a variety of procedures, non-surgical procedures such as injectables like filler and neurotoxin, as well as specific niche procedures for facial and jawline contouring that include buccal fat reduction, submental liposuction, facelift, neck lift, as well. For those of you who are on Instagram, feel free to take a follow, take a look at more of my work, my scope of practice at Dr. Tina Ho, and I have no financial disclosures. So objectives for this presentation today. I'll first review the anatomic considerations when evaluating candidates for facelift and neck lift and discussing the overall aging process in the face and what determines an ill-defined face or neck. Also to review surgical approaches, the latest ones and the ones that I have most commonly now adopt in my own practice when it comes to lower facelift and neck lift surgery, and then to show some real-world examples of how these approaches have been applied in practice and the outcomes in some before and after patient cases. So as we know, the process of aging in the face is it can be characterized by multiple factors. The ideal youthful female face can be described as one that follows a V shape or inverted pyramid structure with good definition in the cheeks, the jawline. As gravity forces come into play and there's volume loss in the face with aging, this pyramid shifts such that the lower face tends to become heavier and starts to lose definition. Multiple factors in the process of aging the face include skin laxity, fat volume loss and descent, laxity of the SMAS and platysmal layers, as well as always good to think about the changes in the bone, loss of mandibular definition and length, particularly with lack of chin projection, as well as loss of the gonial angle. It's also important to take into account 4 specific retaining ligaments and how they play a role in the aging process as well, specifically the zygomatic, masseteric, mandibular, and cervical retaining ligaments. These are essentially fixation points in the face where they hold down the skin and deeper soft tissue structures. And with these fixation points and then the process of aging, there come about certain particular characteristics of the face associated with aging, such as jowling, the pre-jowl sulcus. Now, in terms of the neck, it's not immune to aging as well, and experiences similar processes like in the aging face, such as skin laxity, as well as development of platysmal laxity, also focal adiposis in the neck as well. But there's, I guess there's a shift in terms of who can be a candidate for neck lift. It's not only those who have, or have become older and have shown signs of aging, but those patients who in general have a more ill-defined appearance of the neck. So neck lift now has a spectrum of extending to patients who are younger. In my particular practice, I'm seeing patients as young as in their 20s and 30s who are interested in neck lift, and that's to be able to achieve more definition and contour and balance to their profile, to their neckline, and in essence, for some, even achieve a more youthful appearance as well. So a DITO classification, this is one type of classification that us facial plastic surgeons follow to be able to help identify the best candidates for a neck lift. This is a visualization here where type 1 has good skin tone, minimal fat below the skin. Type 2, the patient has some skin laxity. Type 3, that they have some submental adiposis, blunting the cervical mental angle a bit. And if it's just submental fat, that's the issue. They could be a good candidate for just submental liposuction alone. Type 4, patients start to have platysmal laxity. This is where they're going into the spectrum of potentially needing a neck lift. Type 5, these are patients who are retrognathic, so it's important to consider chin augmentation for these patients, whether it's an implant or something not as permanent like filler. And then type 6, these patients tend to have a low low-hanging hyoid. If you have this patient and you're pursuing neck lift with them, always counsel them on realistic expectations because they tend to have more limited results. So with an ill-defined neck, some may have signs of aging, others have fullness, ptosis of the deeper structures and require deeper sculpting. So that could be beyond the subcutaneous fat where they have platysmal laxity, they have bulk of the subplatysmal fat below the layer of the platysma, bulk and ptosis of the anterior digastric muscle, as well as similar issues in the submandibular glands. Now, in terms of surgical approach, there's a variety of approaches out there. The ones that I'm going to discuss here focus more on the traditional approach to facelift. So I'm not going to talk about, just excising skin, just doing a mini facelift. I think, the common agreement among facelift surgeons here is that the traditional approach where you're addressing both the skin and this mask layer is going to help the patient achieve the most definitive, the most long-lasting results. Varieties of techniques when it comes to lower facelift include SMAS plication, SMAS imbrication, SMAS flap, composite, high lateral SMAS, and the deep plane approach, which this is the approach I'm going to focus on here, since this to me is the most in vogue approach right now among facelift surgeons, across the country, internationally, and it's the approach that I've adopted more and more in my own practice. Interestingly enough, I actually did not train with the deep plane approach. I trained more with SMAS plication, SMAS imbrication in my residency and fellowship. For those of you who are interested in learning more about the deep plane approach or want to adopt it more in your practice, I highly recommend to look at the educational materials for some of the leading facelift surgeons out there in the facial plastic surgery realm. That would be Dr. Andrew Giacono in New York and Dr. Mike Nyack in St. Louis. They are definitely leaders in our field. They have great Q&P video resources. Dr. Giacono has an excellent facelift textbook. So those are some of the key leaders who I have, emulated my techniques after a bit. So some of these approaches like SMAS plication, SMAS imbrication, high lateral SMAS actually involve entering the SMAS out more laterally. With the imbrication approach, this involves cutting a vertical strip out laterally of the SMAS and transposing and tacking it to the mastoid behind the ear. Plication is mainly just tacking sutures to help elevate the SMAS more superiorly and posteriorly. High lateral SMAS, similarly, the approach is to the SMAS out laterally and up high and elevating this, longer or larger SMAS flap from out laterally. The deep plane approach is a bit different. This approach, if you can see in the diagram here, you actually enter the SMAS more immediately. Typically, a plane or a line if you draw it from the lateral orbital rim to the gonial angle. What's interesting, I really like Dr. Giacono's reasoning behind why the deep plane approach works really well is that with the aging face, a lot of the tissues that become dependent, including the SMAS, tend to be more medially. You think about the medial cheek and the jowling and such. So with the deep plane approach, the SMAS is entered more medially and closer to the more mobile aspect of the dependent tissues, such that you can be able to get a more drastic but still natural result by releasing and shifting these tissues more immediately, especially say towards the up higher in the cheek to restore that projection and volume. With the SMAS out more laterally, where some of the other techniques approach these SMAS here, this SMAS is actually fixed. So by going out more laterally, you not only have a longer distance to cover in order to be able to address the tissues more immediately, and this is can be a more difficult dissection as well. Some who may not be as big proponents of deep plane approach are a little bit anxious about it, like myself, in private practice, taking on this technique, is that the branches of the facial nerve do tend to be more superficial medially, so that's a important consideration to have. So in terms of the deep plane approach, this is going to be just a simplified, overview of our approaches, just some key steps that I perform when it comes to performing a lower facelift. In terms of designing these skin incisions, I typically place them in the hair tuft towards the root of the helix, and then along the posterior aspect of the tragus, around the ear lobule, behind or just along the posterior auricular sulcus, and then into the hairline. This really helps to minimize the incisions. I think a lot of facial plastic surgeons typically follow these incisions. Some surgeons prefer to place it right in front of the tragus, but I think it looks like a more telltale sign of the facelift. I also typically approach the neck first. So I'll place an incision in the submental crease about 3 to 4 centimeters. I'll elevate the skin down the neck, out laterally, and then perform the neck lift portion first. Once I then turn my attention to the facelift component, elevating the skin, in the preauricular area along the face, as well as the neck postauricular area. I continue in the neck all the way until it extends and connects with the anterior neck dissection. As for the preauricular area, I continue this until I'm just beyond the deep plane entry point, which is, again, from the lateral orbital rim to the gonal angle. And you can really just draw a line along this mass to know where you're at. With good superior retraction tension by the assistant, and with some retraction with the debaki on this mass for myself posteriorly, I actually gently enter the mass, then with Bovie cautery. I then turn my attention more inferiorly, where I start to create an inferior subsmass pocket. Essentially, you want to look for the platysma, and if you can get right under the platysma, because that's a good plane, you see the muscle well, and the platysma then becomes the mass. You elevate this subsmass pocket, and then you can then switch to blunt dissection and start to take down the masseteric retaining ligaments. The key is to release the 4 retaining ligaments that I mentioned before. One thing to mention, I forgot to mention earlier, is that when I do the neck dissection, I do release the mandibular ligaments at that point, and that really helps to give even better exposure in the neck with the skin no longer tethered. And then here, once you take down the masseteric retaining ligaments, just need to get just beyond the anterior border of the masseter. If you continue a little more anteriorly, this is where you'll actually have access to the buccal fat pad. So for those patients who have a ptotic or hypertrophic buccal fat pad, you can perform buccal fat reduction through this access to help achieve more facial contour here. And then once I'm satisfied with the inferior pocket, I then go more superiorly, staying on top of the zygoma to then develop a superior pocket in the submass plane. I then ultimately find the orbicularis muscle, and I stay on top of that with more blunt dissection. There are some surgeons who do a composite flap, including the muscle. I'm just more conservative in my approach right now, so I stay on top of the orbicularis oculi. And I think it's a good plane to be in. And then eventually you can continue more immediately with just blunt finger dissection into the malar fat pad. That is just nice. It just kind of goes right in here more immediately. So once you have these 2 pockets developed, and really Jacono and Nayak show this in their videos, you can literally put fingers here and here in the inferior pockets, and then you can see what's tethered in between, and that's your zygomatic cutaneous retaining ligament. That's the one last ligament in the face to release. So with good tension, some Army Navies in both pockets, I actually then use Bovie or bipolar cautery to gently take down the ligament in between the 2 pockets. This is where I feel like can make surgeons most nervous. You want to stay more superior. You have the branches of the facial nerve, deeper, but fairly nearby. And it's ligament. It could look like, nerve branches that you're doing this. So in my own practice and adopting this approach more, I've, kind of baby steps with each case I've taken on, gain a little more experience and confidence to take down this, ligament a little bit more and more hopefully releasing as much as I can. And ultimately, if you see the zygomatic major muscle underneath, you're safe. The branches of the facial nerve run deep to this, and this is actually where the mass layer ends as well. So you could convert to blunt dissection, just really peel down, take down the rest of the ligament down towards the modiolus, and then really, again, use blunt dissection, finger dissection to go into the malar fat pad and towards the nasolabial fold. So ultimately, this ends up being like a composite flap where you have this mass, you have the fat more immediately, and with skin. And then for me, I guess because partly because I'm ENT trained, facial plastic surgeon, I really enjoy helping patients achieve as much neck contour as much as possible. I do follow performing a lateral platysmal sling with these patients to really just enhance the cervical mental angle of the neck contour as much as possible. So the last ligament to take down is the cervical retaining ligament. This can be achieved where you make incision along the anterior border of the sternocleidomastoid muscle, along the platysma to release the attachments, the ligament, and then elevate basically a lateral cuff of the platysma. And then eventually you can make a back cut about a centimeter below the mandible. Traditionally, ENT trained, we usually like to enter the platysma more like a couple finger breaths, but if you are hugging the platysma, you do blunt dissection, you should be safe, from the marginal mandibular branch facial nerve standpoint, and just basically elevate this lateral cuff of platysma. Once all of the release is done, then I place tacking sutures, or typically half mattress sutures in this mass, as well as this lateral platysmal sling in a more posterior superior direction. Dr. Giacono will mention usually it may follow the vector of the zygomatic major muscle. So with these tacking sutures, you actually don't have to put much tension on them. You've done all this passive release, and it just shows for yourself. If you redrape the skin, you bring the face or the head back to midline. A good endpoint that Dr. Giacono recommends is if you start to see in the mouth with the oral commissure elevated, the central incisor, lateral incisor, and then you have had a nice elevation. You'll see the shift of the tissues, especially for regaining volume projection in the cheek. So I'll place these tacking sutures. The one for the platysma is towards the mastoid, and then I redrape the skin and then trim the excess skin. And always key to just trim the skin as much, just for the skin edges to be kissing. There needs to be no tension here, or otherwise you could have issues with healing of the incisions and the skin flaps later. Now for the neck lift approach, more traditional approach, and it's what, again, I learned more in my residency and fellowship, is just a more conservative platysmoplasty. So often surgeons may, once they elevate the skin in the neck, enter the platysma at midline, maybe do a little bit of deeper sculpting, but really bring the platysma back together, trim excess platysma, and then place plication sutures. What's really trending now, and it's very popular among my patients now, is a deep approach or a structural approach to the neck lift. And it's really taking into consideration the bulk, the ptosis of the deeper structures in the neck, particularly in younger patients as well. I wish I had like a lateral profile view of the anatomy here, but essentially, so as I mentioned, my approach to the neck lift, even in younger patients, I'll still do a 3 to 4 centimeter incision just to, for myself, get as good visualization as possible. I elevate the skin down the neck as well as out laterally. I'll do some conserved liposuction, and now I've learned as well that you want to maintain a good skin flap, so sometimes more lateral liposuction is helpful. And then release of the mandibular ligament bilaterally. I then enter the platysma at midline with bovie cautery and elevate platysmal flaps from medially to laterally. Then the first structure that's encountered is the subplatysmal fat. So if it's fairly bulky, this can be taken down. Just below that are the bellies of the anterior digastric muscle here. If they're also bulky and orthotic, they can be sculpted well. And then just below the level of that is the mylohyoid. So it runs, as you can see, in basically the opposite vector, different directions. So where you can stop with the dissection. Some surgeons actually remove this muscle. I just feel like it gets really just much closer to the tongue base. So at most, if I see that the mylohyoid is a little tonic, I just cauterize it and leave it at that. And then out more laterally are the submandibular glands. If they're bulky and tonic, that they can be debulked. So the goal is to, sculpt out, debulk these structures. I usually do in piecemeal fashion until there's enough reduction down to the level of the inferior aspect of the mandible. Some key tips when it comes to approaching the submandibular gland. It's very vascular, and you have the the branches, the marginal-mandibular branch of the facial nerve nearby. So I typically inject with local first, let it sit in the gland, and then when I come back, I'll bluntly, make spreads to push the fascia out laterally on the gland. That helps protect the nerve. And then, you try to gently pick it up. It's going to be friable, but then, debulk the gland, going from an anterior and more medial approach to, again, protect the nerve. And this is also a place in the surgery where you want to take your time, because if there's any bleeding, you try to address that right away. There's a potential facial artery. So, it could be, if there's a lot of bleeding, could really add a good amount of time to the case. So I'd like to end the presentation now reviewing some before and after patient cases, just to show some examples of how I've applied the deep plane facelift and deep neck lift approaches in practice. So this young patient in her late 20s came to me as a submental liposuction consultation. A lot of patients, think maybe more minimal surgery, maybe they may be the best candidate for this surgery. We ultimately pursued a deep neck lift where she had bulk of the subpalatal fat as well as digastric muscle. Some key things on exam that helped me determine whether they're more of a neck lift candidate versus just a liposuction candidate, where sometimes virtual consultations is limited, but definitely in person is always most definitive. If I really see an obtuse cervical mental angle, it's really blunted, that steers me more towards the neck lift. Also, when you start to see the patient, if you have them swallow and if you have them engage their neck muscles, if you see a lot of that fullness reduces, kind of sucks in, or also that it kind of moves around, that you can tell there's bulk of the deeper structures, that just some liposuction isn't going to cut it for this type of patient. So I actually, had talked to her about, an implant could be helpful just because she's more prominent nose, but often sometimes it surprises us with the actual surgical result that their profile is more balanced, that that they maybe didn't really need a definitive chin implant. This patient, she similarly wanted to improve her neck contouring. Actually, she was a patient from out of town, and when I saw her virtual consult, I talked about options. Sometimes there's a spectrum of, maybe liposuction is reasonable, but I always want to counsel, if you want that snatch look, the most definitive result, neck lift is best. Some patients may say only neck lift. And so she was open to the, more drastic approach with surgery. When I saw her in person, I was actually a little then surprised that it didn't seem, as full and as bulky, but actually intraoperatively, and this is what a lot of times nicely confirms for me, after just liposuction, the area really didn't reduce that much. So it gave me, the extra reassurance and confidence, that we needed to go under the platysma and sculpt out the digastric muscle and fat, the subpalatal fat as well. This young patient, she also, thought that she might be a subpalatal liposuction candidate, but especially with the thin skin and just, how full, how, blunt that angle was for her, I knew, even from a virtual consultation, that she would need more of a neck lift approach. And she was someone where not really much fat underneath the skin, and she had really bulky anterior digastric muscle. So, and it's okay functionally to remove all of this muscle. At first, when I thought about this approach, I thought, this sounds crazy, right? Removing all these structures, doing all this, deep dissection. But as a surgeon who's ENT trained, we take out submandibular glands all the time. We also do oncologic resection for cancerous lymph nodes. This is essentially like a level 1A neck dissection. So functionally, it's okay to remove these structures. And as long as the anatomy well, and don't, over resect, then you can help patients achieve these nice, more definitive yet still natural results. This patient, she additionally had a closed rhinoplasty, but she pursued also a deep neck lift with me, requiring muscle as well as fat to be removed. What's interesting for this patient that I would say she's in her 30s. She looks older than her stated age. So I did do some more lateral liposuction as well, but you can even see not only is her neck contour improved, but her lower face, with some jowling, some ill-defined, jawline definition, that she actually has, rejuvenation, looks younger in the lower face. This patient in her 40s, she had previous liposuction, wasn't happy with her results. So we talked about doing the, more aggressive surgery of a deep neck lift. She has good skin tone. So, and for me, how I discuss patients about neck lift approach. I'll tell a patient that a mini neck lift is, even though it's still doing the deeper sculpting, is one where I don't remove the skin. So I don't do the traditional incisions behind the ear. Those who require just a true neck lift will likely need some kind of skin excision more posteriorly. So, I felt with this patient, even though it was her 40s, she had good skin tone. She didn't have as much signs of aging in the face, the lower face. So we ended up pursuing, we also did a revision rhinoplasty, but also a deep neck lift as well as a chin implant. And then you can see just, not only improved contour, balance to the face, the profile, but, looks more rejuvenating, kind of, looks like she, lost a good amount of weight to her face. So this patient, she underwent a facelift and neck lift with me. Again, a lot of times I tend to attract patients who are most bothered by their neck, and she actually was just a liposuction consult at first. When a patient is, older, maybe more 40s, 50s, 60s, and I see aging signs of the neck, I do try gently to counsel them to, say it would really benefit for you to address the facelift at the same time. Even if the neck has the most drastic result, just think the neck lift only stops at the jawline, so may not, address issues like jowling, the lower face, lack of definition as well. And think with the facelift where it just adds a little bit more time, a little bit more expense, one period of downtime, but you're going to get the greater global result. And then what you can see in her before and afters. Yes, the neck is the most drastic result, but even just, with the mid-face, how the tissues were more dependent here immediately, and now that they have shifted, with better cheek projection and volume, and in a way that you don't have to rely as much as even on facial fat transfer if you're able to get a good result with the deep plane approach. Another patient here, again, was most bothered by her neck. We ultimately pursued a facelift and neck lift. And if you can see, the nasolabial folds, with a good resuspension in the mid-face, are softer. You have that restoration of the, cheek projection and volume as well, in addition to the improved neck contour. And then, so I'd like to present one last case. Male patients deserve facial rejuvenation as well, even though the majority of my patients are female patients at this point. So this gentleman, he came to me, desiring a facelift and neck lift. He's someone who wants to work a bit longer. So just wanted to, be more refreshed and kind of feel like he's, looking and staying in the game, from a professional standpoint. He was someone who had, a very tough neck. So I ultimately not only, sculpted deeper fat, digastric muscle, I also resected his glands. He had large glands. And so that helps. If you're able to pursue gland resection, that can really help get you what's, as Dr. and I would say, more towards the A+ result. Otherwise, if I hadn't removed them, there'd just be some residual fullness still. And he did require a good amount of skin excision. And you'd actually be surprised, with the neck lift, with how much, and facelift with how much skin is actually trimmed. It's at the end of the case, it's really not that much. So it really relies on resuspending that SMAS latissimal layer, and then the neck, the deeper sculpting. So thank you so much for your time and for the opportunity to present today. Again, I'm Dr. Tina Ho. Feel free to give me a follow on Instagram, Dr. Tina Ho, to look at more of my scope of work. My email address, tweetmatinaho@gmail.com. I apologize, I can't stay later for the Q&A session, but I'd love to field any questions you have, or anything more about this approach, and happy to direct you in the right direction for other educational resources. So thank you so much.
Does anyone have any questions for Dr. Ho? Tina, I have one question for you. For deep plane facelift, there's a little bit of a spectrum, right? So some people will do a more extended skin dissection because they feel people have more actinic skin changes, and some people really limit the skin dissection that they do and say that it's really the release and not so much. So where do you fall on that spectrum, and how do you think about how much skin subcutaneous dissection to do and how much skin to take out?
So right now, I mainly do it just beyond the deep plane entry point. I would say my patients are not along the lines of the more sun damaged, or patients in their 70s and 80s. So maybe my scope of practice might change, or my approach might change for those practice if I had more of those patients. But I tend to be more conservative in terms of not feeling like you have to excise so much skin. You can always, if they have a lot of sun damage or rhinitis and such, pursue additional CO2 laser, on top of the facelift approach to get that extra rejuvenation. But really, even in that gentleman, even if I probably excise more skin on him compared to my other patients, still at the end of the case, it doesn't look like as much skin as you expect. So I would say I'm probably still along the less aggressive when it comes to skin resection. It's having attention and care to the deeper structures that should be as important.
Great, Tina. Thank you so much for excellent talk and about your approaches, especially for your neck lifting approach. And thanks again for visiting Wellesley Hospital. We appreciate your time.
Thank you so much.
So I'd like to introduce the next speaker, Dr. JP Ulloa, and he's going to be talking about buccal fat sculpting.
All right, good morning. All right, my name is Jan Ulloa, and I'm going to be talking about buccal fat sculpting. So unfortunately, I don't have any financial disclosures. In fact, we validate parking. So here we go. These are three pictures of three very cosmetically oriented ladies, and no one can say that they're very beautiful. They have beautiful eyelids, full cheeks, slender jawline, full lips. But what else do they have in common, and what else can we do to help people achieve this look? So we're going to talk about all these type of things along this morning, but right now we're going to talk about buccal fat sculpting. So the true name of these fat pads is called Bichat fat pads, and they were described originally by a French anatomist, Xavier Bichat, in 1802. And it's interesting because he was a pathologist but did not use a microscope and did not believe in the existence of cells, which I thought was pretty interesting too. But he has described a lot of anatomical findings in the human body, and this fat pad consists of three lobes: anterior, intermediate, and posterior. Basically, the anterior lobe is confined to the buccal space, and it is the one that has a little bit more structures around it that might, we have to keep them in mind when we're doing this surgery, including the parotid duct, the facial artery and vein. The intermediate lobe is the one that loses volume along throughout life, and it is the reason why children tend to have these full cheeks and full face, and then it slowly loses volume. And the posterior lobe, which is the most significant, it has a temporal extension under the zygomatic arch, and this fat pad is actually the one that contributes around 50% of the fat pad volume, and it has an extension into the buccal extension, and this is the one that we are sculpting for cosmetic purposes. Basically, it is between the masseter and the buccinator muscles, and we can see here along the superior edge of that fat pad the parotid duct, which is going to be important to identify for our approach into sculpting these fat pads. So who is this for? This is the ideal aesthetic surgical candidate for this is the one that has prominent cheekbones, but then it's masked because of this fullness in the cheek. These patients lack that angular appearance in the face, And then reducing this fullness will achieve this slender look and the prominent zygomatic bone. Malar hypoplasia is not an indication for buccal fat fat removal. That is actually the opposite. We will want to augment this appearance of malar hypoplasia if we see this in a patient. So how do we do it? So the first thing is there's two approaches. The first approach would be the intraoral approach, and it's actually the easiest, at least in my opinion. And what we have to do is identify Stensis duct, right? That's the opening of the parotid duct into the mouth. It emerges from the parotid gland and runs on a lateral side of the masseter muscle and opens up both sides along the maxillary second molar. Once we identify that, it's a matter of incising it 1 centimeter below. So there's this great paper that I found. Let's follow the Ds, right? The 5 Ds for safe infected buccal fat fat removal. And it just simplifies this surgery. And it basically goes ductal identification, incision is performed 1 centimeter below. Dissection is, the direction of the dissection is posterior encephalic. Deliberate basically means putting a little bit of pressure on the outside of the cheek and gently tease out the fat without overexpressing or pulling. Debulking, you cauterize the base and remove the fat. Approximately 4 to 5, some people do a little bit less of fat that are removed, and then comparing both sides to achieve symmetry. So this is also video from the same authors from on this paper, Dr. Jalal Abadi.
Buccal fat removal, there's some key points. This is Stenson's duct. You want to go centimeter below it. You can almost see that fullness there. You want to go below it, and then you want to get local in that area. We will do a little like cautery on low level. Then we will get a hemostat and thread through the buccal, pushing up on the lateral aspect of it and suctioning in that area where we suction. And then if we can move this gently. And we can see she has a modest amount of fat in the face. So going through the box center and then we pull it out. You can see she's got a moderate amount on both sides. And we will then gently cauterize the base as we see it. So we again have modest amount of fat here. We'll compare it to the other side. It is similar.
That's basically it. So there's another way that we can also do this. It's through the face flap, which Dr. Ho explained beautifully. Once we are in the deep plane, once we incise that S mass, getting into the buccal fat pad is just a matter of bluntly spreading and removing it. And then we have a great video here from Dr. Ramesh. So skin flap, mouth flap, deep plane. Zygomatic exchange to ligament here. We have the zygomatic major muscle here. We have now muscle fat here. And that would be another focus of the surgery, but once we are under the S mask, it's a fairly straightforward buccal fat pad sculpting. So this is a beautiful result. Besides the orbital decompression that the lady also, was performed on her, we can see a very nice, subtle, slender look on the face and on the cheeks and the mid face. And it's important not to over resect because we want to avoid that hollow appearance. And these are other sample photos that I also found from different surgeons, Dr. Kwan, where we see that reduction in fullness, and it really gives that look, slender look in the face. So it seems easy, right? What can go wrong? Well, there's a couple of things that can go wrong. We can over resect and cause some, over hollowness there. And obviously these ladies, it's debatable whether this one had an over resection. Some people might say that she did, but and then this one, I think that she could have gotten a little bit less. And what other things can go wrong? Just the standard things: infection, bleeding, facial nerve damage, parotid duct damage, and asymmetry. So what did I learn from Dr. Bashad? Basically, what we learned is the buccal fat pad is straightforward procedure that provides an aesthetic outcome to the right patient. There's two methods of accessing this fat pad: is intraoral or via the facelift flap. Taking less achieves a way better result, in my opinion. And remember to discuss it with the patient, because this is something that I often forget to look at, especially if I'm focusing on the eyelids, brows, and just overall facial volume. I forget to mention this or look at this. So I'm going to incorporate this. What articles can I use to read more? These are my references. And then I want to acknowledge my program director, Dr. Morgenstern. Thank you so much. I owe him more than I can ever really repay. Dr. Krasko and Dr. Ramesh, for everything that they have taught me. I'm very grateful. And obviously, my 3 MVPs, mom and dad, and my wife. Thank you so much. All right.
Thank you, Dr. Ulloa. That was a great talk. So I have the pleasure of introducing our next speaker, who really needs no introduction here at Wills Eye Hospital, as he is definitely a friend to Wills Eye Hospital. Dr. Ken Morgenstern is an occulofacial and reconstructive surgeon. He has practices in Wayne and in Lancaster, Pennsylvania as well. Dr. Morgenstern attended the Medical College of Pennsylvania here in Philly. He did 4 years of a general surgery residency at MCP Hahnemann, and then I would say saw the light and went to ophthalmology and did an ophthalmology residency at West Virginia University, and then continued on to several fellowships, the ophthalmic and facial plastic surgery fellowship at The Ohio State in Columbus, Ohio, with Ophthalmic Surgeons of Ohio with Dr. Cahill and Dr. Foster, who was actually just here on Wednesday as our visiting professor. Dr. Morgenstern is extremely active and has held key leadership positions within our society, the American Society of Ophthalmic, Plastic, and Reconstructive Surgeons, and is actually slated to be the president in the very near future. So it is my pleasure to introduce Dr. Ken Morgenstern, who's going to be speaking about facial implants. Thanks, Ken.
All right. Thanks, Jackie, for the introduction. She said I'm a oculofacial plastic surgeon, and my practices are in Philadelphia. I've been here about 20 years or so. Mainly, I focus just on facial plastics. We're probably about 70% aesthetics, and the other 30% is still our love of our reconstructive stuff. So today, we're going to talk about facial implants and addressing volume loss and facial aging. I think with the topic of aesthetics and faces, you're going to hear a lot of the same things kind of reiterated over and over again, but those are going to be the important things to take home. And a big part of what we do isn't necessarily just the surgery. It's about really being able to assess the patients and knowing what we do. Having the tools in our toolbox is important, but knowing how to use them is even more important to getting some of these really nice outcomes. Okay. So let's start backtracking a little bit, and let's talk about the aging process, because this is really what helps us determine what we do. The first thing that happens with facial aging is the skin. It changes. Up until about ages of 20 and 24 years old, we're laying down new collagen, new elastin, and then that process stops. And then the collagen and elastin starts to degenerate, and our skin gets kind of wrinkly, and we lose the volume, and you start to get sun damage and stress. And so that's the first part of facial aging. The second part is that we lose fat in our face. We may gain fat in other parts of the body, but we certainly lose it in areas of the face. And when you start to deflate, that kind of gives you this sort of cachectic look. And that support structure that holds up the cheeks and holds up the mid-face starts to wax, and now the face starts to drop. And then the third part, which we also often overlook, is the bone loss. So my analogy that I talk about is it's kind of like a pebble in a creek, right? The water chronically just kind of runs over that pebble and remodels it over time. And the same thing happens with our face, with the bones being pulled upon on the muscles, facial expressions, just normal cellular degeneration. The bones start to flatten and change. And that's also our support structure. So as those bones start to flatten, again, that support structure that holds up our cheeks and holds up the volume and the upper part of our face starts to wax, and the face starts to drop. So we've probably all seen this photo before, and Tina showed this in her own sort of character. When we're young, we have this sort of reverse teardrop volume. We have more volume in the upper part of the face, and it sort of comes down to more of a point in the lower part of the face. But then as those structures of the fat absorbs and the bone starts to absorb, we go from this sort of V shape to more rectangular shape. And then eventually you start going to the upside down V, or the triangular shape. And this is all cues that we see when we talk to people that the face is aged or there's some sort of stress involved. Well, how do we address these changes? Well, we use skincare, we can use different types of lasers, we can use injectables, and of course, there's surgery. How do you choose? Well, again, it's all about understanding what the aging process, what the issue is that we're trying to address. If you have skin issues with loss of elastin, we want to stimulate that. We have chemical peels, we have lasers, things to try to generate more collagen or more elastin. The lasers can help us do this. It can also address some of the sun damage issues. And of course, injectables. And I don't think we're really talking about injectables today, but it is one of the most commonly used tools in our bag as far as addressing that volume loss and trying to create that rejuvenated look. And of course, there's surgery. And surgery, we try to reserve for anatomic changes. So what are our goals? Well, our goals are to minimize the appearance of the fatigue. We want to restore the youthfulness and improve the overall aesthetics. We do this by adding volume. We do it by eliminating wrinkles or minimizing them. We want to do it by addressing the extra skin or the baggy skin, such as Tina talked about, with removing some of it with the facelifting and neck lifting. And we want to reestablish good symmetries. The key with this is being able to do all of these things and still maintaining normal function. Addressing aesthetics is great, but if you're addressing aesthetics and causing functional problems, that's not so great. So looking into our trick bag, we can take a patient that's like this, who's had all kinds of these issues with the skin issues, the volume loss, even some of the bone loss, and we can create an outcome like this. But this is not just from one modality. This is not just from implants. It's not just from facelifting. This patient had an endoscopic brow lift, an upper lid. She has tear trough implants in there. We've done a facelift, a neck lift, and we've also done some lasering to recreate a more rejuvenated and volumized face. So let's get focused a little bit. Let's talk a little bit about the eye rejuvenation. So Jackie's going to talk obviously a little bit more about this and in more detail, but let's talk about lower lid blepharoplasty. So traditionally, we rejuvenate the lower area by either a transconjunctival approach or a transcutaneous approach. The transconjunctival approach, typically we make an incision 3 millimeters below the lower lid tarsal plate. We go through the lower lid retractors, come down over the septum, down to the inferior orbital rim, and then we can sculpt, move, or do whatever we want to the fat pockets that are there. We can do it with or without skin removal. We can do it with or without lasering to help to regenerate as well. There's a transcutaneous approach too, where you make a subciliary incision, create a skin muscle flap. Also, basically the same technique, just coming anterior versus posterior. And again, you get down to that fat pad and we can remove it, sculpt it, do whatever you want to try to create a nicer contour. So this is a patient of mine, it's probably about 18 or so years ago, and she came in with this standard sort of bagginess, tired kind of look on the lower lids, and she wanted to address this. And I did this with a transconjunctival lower lip blepharoplasty, and I did a little CO2 laser on it. And at the time I looked at it and I thought I was pretty happy with that outcome. But then over time, I kind of felt that I needed to do more. I felt like that the lid looked nice. You know, I addressed some of the skin changes. I addressed some of the puffiness there. But, you know, did I really make her look any younger? And so when I look at the lateral view, that's where it starts to kind of come into play. This area sort of right in here where she's had some volume loss. Now, I didn't address that with my surgery. I didn't do any volumization. I didn't do any fillers. I didn't do any implants. I made her lower lids look better, but I don't think I really addressed the other two factors of facial aging, right? I didn't really address the volumization, the fat issues, and I didn't really address the bone stuff. All right, so how do we take this to the next level? And that's kind of what I'm going to talk about. So specifically in tear troughs, we have various volumizers. You can do fat translocations. We can do fillers, such as the hyaluronic acids. You can do fat transfers and implants. The fat translocation is a relatively common technique. You know, you do your lower lip blepharoplasty, open up the fat pads, sculpt them, move them. Various techniques with taking 4/0 silk sutures, grabbing it through the fat pad, bringing it out through the cheek, maybe sewing it over bolsters to kind of drape it out and add volume that way. Certainly some perks to that technique. You can use fillers, so you can do your surgery, then use their hyaluronics afterwards, add the volume back. That also creates a very similar sort of outcome. Downside of fillers are they're temporary, right? So you got to have a patient that's willing to come back every year or so to continue to add that volume. And then you've got fat transfers. And people either love fat or they don't love fat. I'm more on the adage that I'm not a big fat transfer guy. I know Ramesh is going to probably change my mind with all of that later, but you know, my theory with the fat is, you know, you have to harvest it from somewhere. We spin it down, we re-inject it. And there's various nuances where you take it from, how you do it, how gentle you are, what speed you spin the fat cells down and re-inject it. And then, you know, in the right patient, this can be a nice permanent fix and you can have a nice normal outcome and it's something using from the patient. You're not using something synthetic that you bought off the shelf. But sometimes it melts and sometimes it's lumpy. So it has its pluses and minuses. So that's where the implants come in. So the implants are a nice way to volumize. It is what it is. It's a permanent fix. It doesn't, patients don't have to keep coming back for more of it, but it's also an implant. And there is there are patients who just don't want those implants or that scares them to have something foreign placed into the face. So again, I talked a little bit about this. We won't spend any time here, but the fillers, fat, silicone, most of us don't use that anymore, and hopefully you don't encounter it anymore. Collagen, also a little bit more cumbersome to use. Again, most people aren't into the collagen. The hydroxyapatite fillers, probably not a great adage for around the eyes. The polylactic acids, again, inflammatory kind of filler, probably not a great use around the eyes. And then the hyaluronic acid. So if you're going to use it, that's what I would recommend. And I think that's what most of us do now. Again, we won't go into a lot of detail, but fat harvesting, there's all kinds of places you can take the fat. Subumbilical is a great spot, behind the knee, hips, all kinds of areas. Take the fat, especially if you're going to do lipo anyway. And again, in some patients, it's using their own body to add volume, and it's preferable. Okay. So what happens when the fillers fail? So here's a patient of mine who came in and he had these really bad dark circles under his eyes, and he had tried to address this with fillers. And I think if you look at the picture, he's got a relatively nice effacement of the tear trough area. The problem with this is it required so much filler to get that kind of result that he now has this sort of Tyndall effect. He's got this bluish hue, and he wasn't really satisfied with that. And this was done by his dermatologist, who excellent dermatologist, very handy, knows what they're doing. So we took a look at this, and he said, all right, well, let's start from scratch, right? Let's take out the fat. Let's take out all that filler. Let's see what we're really dealing with. And what you can see is it's got a really hollowed out tear trough region. And he's never had surgery or so before. But obviously fillers aren't going to do it. So really what's left for them is either fat grafting or implants. And we had this conversation, and he wanted something that was a little bit more predictable. So let's talk about implants. So the implants that I use mostly for facial augmentation or rejuvenation are silicone based. I like the silicone ones because they're easy to put in, they're easy to patients with them. Rarely do we have to take them out, but in that one circumstance, you might need to do it. You want to be able to do it easily. Some of the porous polyethylene ones or the integrated ones can give you some problems afterwards, especially if there's some inflammation with those implants that can create havoc on your aesthetic outcome. So the ones that I use are, you can get them right off the shelf. They're small, medium, and large implants. They vary in the length, the height, and the width of the implant. You do have sizers that you can autoclave and use intraoperatively to help you choose which one. I'm sort of at the point now where I don't really find that the sizers are helpful. Kind of assessing your patient, talking to your patient, understanding what their outcomes are, looking at their cheek projection, the submalar region. You just get to know which kind of implants are the right ones. They also make extended implants. This can be helpful if somebody wants a little bit more prominence over the zygomatic arch, or wants to create that little hollowed area beneath that area in the submalar area. So just like Dr. Ujo was talking about dressing the buccal fat pad to create more of a contour, you can use it sort of an extended implant to also create that appearance. And then finally, they're custom. So I mentioned at the beginning of the talk, you really do have to know your patients, know their history, know what you're getting into. Patients with congenital deformities, or trauma, some of the off-the-shelf implants might not fit perfectly well. One of the benefits of using a silicone is you can sculpt it and cut it and shape it as you want, but they also have custom implants. And essentially what we do in these patients, and I'll show you a picture of one of our craniofacial patients, but you take a CT scan, they do 1 millimeter cuts, they do a 3D reconstruction, the company then sends you the program, and you do a sort of a Zoom talk back and forth. You can sculpt it every way you want to do it before they actually print it. They do a 3D print of it. They ship you the implant. It's sterilized, and it fits perfectly right into that spot for that specific patient. Now, on the other side of the slide, on the left here, or your right, is our approach for when we do tear trough implants. I do a transconjunctival approach. Sometimes I make a canthotomy, sometimes I don't. This one I'm just showing you because it's a better exposure, easier visualization. Same approach as I would be doing a lower lip blepharoplasty. I come right down to the inforbital rim, I score the periosteum, and the rest of the dissection is all subperiosteal. We're all familiar and comfortable with the subperiosteal plane, so this is so far nothing new or tricky about it. When you make your dissection, you're going to dissect down along the malar face just to the right size of the implant. That is key with placing implants. You want to create a pocket where the implant just fits nicely so that it doesn't move and it doesn't shift. This enables us not to have to use screws or any kind of fixation devices, which is also a benefit of the implants. The other trick with these is making sure that you really delineate out that infraorbital bundle, which you can see in the picture here. I do go medial to it. I try to come around inferiorly to it. The reason I do that is I want my implant to sit nicely, snugly just around the nerve. Again, the implant's not going to move, so you shouldn't have any issues with the nerve afterwards. And in the last probably 18 years, I've never had an issue with it, as long as I come around medially and really dissect and create a nice little pocket there. Once I get the implant size, I irrigate the pocket with a diluted antibiotic solution. There's no science that shows that actually improves my outcome. It makes me feel better. That's why I do it. I get the implant in place. I don't fixate it. I close the periosteum. I use vicryl sutures. That periosteal closure is key, I think, for any implant, so that a nice tension-free closure. If you have any tension on a closure with an implant, that implant's going to want to try to extrude. So make sure it's a nice tension-free closure. I close the conj with a single vicryl suture buried laterally. I replace my canthus, and that's done. The patients rarely have any pain after surgery. There are no pain pills. We do put them on a little bit of steroid afterwards to decrease the swelling. Again, anytime you're doing a fracture or you're doing an implant like that, you're going to have edema. So we put them on a Medrol dose pack for the first week. And we tell them that for about 6 weeks, you're still going to have a little bit of noticeable swelling. But again, very minimal bruising, very acceptable quickly. Okay, so here's that patient that I showed you before. And this is after the implant. So no blepharoplasty, just a simple implant. Again, part of being a plastic surgeon is being critical of your outcomes. And I think he's had a very nice outcome. He's happy with it. In retrospect, I'd probably use a little bit bigger of an implant, try to get a little bit more medial volumization. But overall, big difference, and the patient's thrilled with that. So this is just another one of our standard patients. She came in sort of an aged face, didn't like the lower lid bags. But not only does she have the lower lid bags, but she also has that sort of malar hyperplasia, or that volume loss. So here we did a lower lid blepharoplasty, transconjunctiva, no fat removal. We used a small tear trough implant, and we did some lasering over top of the skin. Again, this is a little bit later in my career. I was a little bit better at choosing the size of the implants. Another example, this is a younger woman. She's an actress from New York. And her main concern was her makeup artist was having a hard time covering the darkness, and she was getting kind of frustrated with it. You can see she has a little bit of the steatoblepharon, a little puffiness on the lower eyelid, but the main concern is that hollowness. So same deal. We went in, no blepharoplasty for her, but we did do the same approach. Again, a small implant to help efface that tear trough region. And in the chin up position, you can see the significant improvement on the of that malar hyperplasia, of that tear trough region. Now, the other benefit of using these implants is they're long term. So once you put them in, they're not changing. And because they're subperiosteal, you don't have to worry about them ever showing or demarcating. So same patient, again, this is her 1 year out with the lateral view, and then again at 10 years out. And you can see that the face has changed. Her skin quality has changed a little bit. Mid-face has dropped a little bit, but that implant hasn't moved, and that lower eyelid tear sort of cheek junction has maintained a nice appearance for her. So I mentioned that you can use these also in reconstructive things. This is just one of our craniofacial patients, a Pfeiffer syndrome. And again, using a nice implant, transconjunctival placement, we can augment that region. She's also had a little canthoplasty to increase the angle of the eye as well. Okay, so the implants aren't just for around the eyes, they're also for full face augmentation. Malar augmentation is a little bit different. It's a different implant, it's a different placement, it's a little bit more lateral, it has a little bit more projection. The submalar region must have volume when you put these implants in. We've all seen patients come in with cheek implants that just don't look right. And it's not so much the fault of the implant as much as it is the assessment of the patient, making sure that the patient's face can handle the cheek augmentation. They need volume in that submalar area. How do we place them? I still place these transconjunctivally. And the reason, again, I like to do that is because I'm creating just a pocket which is big enough to fit the implant, and I don't have to secure the implant. You can absolutely do these intraorally. Our OMFS colleagues do that all the time. The problem is that when you come from intraorally, you do have to fixate it because, you have this, your incision is inferiorly. There's really nothing stopping that implant from moving downwards. They come in small, medium, and larges. Again, you just really want to choose the right implant for the patient, create a normal appearance. So just like we were talking about before, taking a patient like this with multiple different issues of facial aging and addressing it with cheek implants, lasering, and lower lids, you can create a nice, more youthful look and volumization, and one that doesn't look like they're implants. I should say that the implants, again, I mentioned before, are subperiosteal. These are not submuscular. And in the past, one of the problems with the implants were people were placing them submuscular, and that created all kinds of issues with demarcating. So definitely all these implants are subperiosteal. So just like I was talking about, the placement matters. Using an implant for cheek augmentation and tear trough augmentation can, again, create a much more youthful look. Submalar implants. So beyond the cheek, beyond the tear trough, you've got that hollow beneath there. And just like in the picture I showed you before, that kind of cachectic aged volume loss thing that we see in the weightlifters and our runners, Even the patients who have a more vegan diet, they really get the hollow out in that area. It makes them look more tired. They feel better. They may be more healthy physiologically, but aesthetically, not so much. It's like the tear trough. It should not be seen. None of these implants are to be drawn attention to the fact that they're implants. Again, you're using them to augment the bone absorption and the volume loss. You're not putting implants in so that people can look at them and say, that they have implants. These implants fill the submalar space. They replace the non-surgical approaches. So there's certain types of fillers that we talked a little bit about before, not the scope of today's talk, where you can inject in the midface to add that volume back. HIV patients, other chronic conditions which can cause the volume loss. In the past, really, it was all fillers. Again, the submalar implant is a nice option where they don't have to keep getting the injections. These are placed beneath the malar prominence. They can be used with other kinds of implants, which are nice. If you're going to do that, though, you probably are going to have to fixate this. Really trying to get 2 implants through a transconjunctival space is a little challenging. This is something that I would either use a dual approach or just come intraorally. And then, like I was saying, these may need fixation. Okay, so Tina talked a little bit about chin and neck, and you can't really talk about chin or neck without talking about one or the other. For me, I think these are the easiest of all the implants to place. They help with projection. They can help broaden the jaw. They can lengthen the AP projection. Can help with the appearance of the jowling as well without doing surgery. Although most of the time, if patients really do have a prominent jowl, we are going to be talking about facelifting and neck lifting in conjunction with placing these implants. Again, these are subperiosteal placements. One of the little tricks is to limit your pocket. So any of us who do the facial aesthetics, we've all seen implants that people have placed, and maybe they were great for a period of time and for whatever reason may have shifted. One of the tricks is really create that pocket with just the right size. Go small, place your implant, doesn't quite fit, add a little bit more dissection just until you get the right size, and then that implant slips in nicely. You got to line it up perfectly with the midline. Again, no fixation. Submental incisions versus intraoral. I was trained doing an intraoral approach. It's really easy to do, but again, it always makes me uncomfortable to go through the mouth down into that pocket and then place an implant. So I switched, and now I do a cutaneous approach. If you're doing a neck dissection or submental liposuction or anything else, you're going to be right there anyway. So just extend your incision right down to periosteum, subperiosteal dissection. The other trick is before I place these implants, I always mark my midline. It's easy to lose your dimensions once there's a little bit of swelling or once you have some local in place. So all my markings are done before I do any of that, so I know exactly where my midline is. So here's one of our younger patients. She was concerned about the appearance of her neck and projection of the chin. And we did a little chin implant, a conform implant. We were able to give her a little bit more volume along the jawline. And then with a little bit of liposuction and increasing that AP junction, have a nice sort of youthful appearance to the neck. She's super happy with that. And it doesn't take very long to do. And there's very minimal bruising. There's really no pain. The incision you have beneath the chin heals nicely, just as long as they continue to take care of it. The only other implant that we're going to really talk about today are the temporal implants. This, of all the implants, is one that I rarely do, but it is out there and you should know it's there. Most of the time, if we're trying to address the temporal hollowing, I will use fillers for this. This implant, though, is not subperiosteal. It's not even submuscular. It is a subcutaneous placement of an implant. There really is no correct placement of these things, which baffles me. You really just make a hairline incision, a subcutaneous dissection, create a pocket, place the implant, and close it. It's super easy to do. I think I get a nicer result with fillers more than I do with the implants. I think sometimes these look a little bit like implants because they're subcutaneous, but they're certainly out there and they're available. The other thing about the silicone implants is they're relatively inexpensive. You know, when you start getting into some of the more complicated ones and the porous polyethylene ones, and then of course the custom-made implants, those can get quite pricey. So just a quick example of a temporal implant. You can certainly improve the appearance of the hollows, but I think I can almost get a better result with using the fillers, and the fillers can certainly last you a couple years, the kinds that we place in those regions. With all surgeries, there are complications, and you need to know that. So whether or not you're doing a facelift and all that wonderful, muscle sculpting and working with the submandibular glands, just like you can get fistulas and drainage and seromas with all of those kind of things, you can get complications with implants as well. If complications are relatively few, but infection is the one that we all sort of worry about the most. This is a biofilm that developed on this patient. She had a little bit of redness that developed probably about 10 days or so after surgery, a little bit of swelling, never any purulence, no infection from that standpoint, but it did take us 2 rounds of clindamycin to clear this up. But the end result is she's totally happy with it, and the infection goes away, and you don't have to remove the implants. In the old days, when we did implants, we got very worried about that stuff. We always went in, we removed the implants, we healed up the infections, then we went back and we reconstructed. Then we got a little bit more bold and we started treating with antibiotics and watching the patients. Nowadays, most of the time, if you're going to get these problems, we just treat them aggressively with the antibiotics, and our outcomes usually are just fine. Okay, so in summary, skin, fat, and bone all change with facial aging. And the key with any of the things that we do is understanding what we're seeing and why we're seeing it. And that's how you choose. Does the patient need a filler? Does the patient need a laser? Does the patient need an implant? Do they need fat augmentation? There are lots of modalities to choose from. The key is to pick the right one for the right problem. Implants can be really a nice permanent alternative for the bone loss and volume loss of the face. Patients are happy, and the postoperative care is relatively easy. Okay, thank you so much.
Those are beautiful results, Ken. As a quirk of geography, I've been fortunate to see a lot of your patients 10, 15 years down the line from implant placement, and they're very happy with their aesthetic. One question I have for you is, one thing I worry about is the micro movement of these implants potentially causing bone resorption long-term, which is one reason why if I place an implant, I like to fixate it with screws, particularly in the mid-face, where sometimes if they have a curve in their zygoma and you want to get that implant really flatly against the bone, how do you handle that scenario?
Yeah, so it's a great point. So just like the analogy that I had said before about the water running over the pebble and causing a remodeling of the stone, Ramesh's point is that when you put these implants in, you're going to have some facial moving. The implants are going to move with the muscles kind of pulling over top of them. So aren't you going to get the same kind of bone resorption? I think it's a good point. I think placing a screw or microfixation has its pluses and minuses too. So I've certainly seen patients who've had the implants in and they're screwed in, and now we have issues with the screw or overlying inflammation or bony changes from that. So, when I place the implant, I try to make sure that implant sits as comfortably and as snugly over top of the anatomy. I make sure I do a good history beforehand, make sure there's no trauma. Sometimes they're not always honest. Sometimes you get in there and you're like, oh, this patient totally had, a LaFord fracture, something where the anatomy is different. And so I guess to answer the question, I try to do the history well. I try to choose the right implant. I try to get that implant to fit as snugly as possible. And it's a conscious decision for me. Do I place a fixation device to prevent the micro movement and the microbone, or do I not go down that road? Right now, I prefer not to fixate it and to accept that maybe there's some microbone absorption, and hopefully that won't be so noticeable in the future.
So to follow up on that, you mentioned the right implant. I noticed up there you have a picture of the Flowers silicone tear trough implant. Have you tried also from Implantech the Conform implant, which has a little more moldability to it?
Yeah. So with the chins and the cheeks, I use the Conform. So what Ramesh is talking about is the Flowers tear trough implant. It's just a solid piece of silicone with a little notch in it for the infraorbital nerve. They make these softer ones, implants that have these little nubbins on the back that can conform a little bit better. And the concept is that it'll help to address some of the bony irregularities a little bit better. The chin, I only use the conform, and the cheeks, I only use the conform. I haven't used them for the tear trough region though.
Any other questions?
Ken, I have a question. Great talk, good discussion of the implants, and I know you're a fan of these, tear trough implants. JP tells me a lot that I should do it. So thank you. So in general, how much, generalized cost are these implants? They're silicone, maybe they're not that expensive, but perhaps I'm wrong.
Yeah, no, they're only a couple $100,
Okay.
which is really nice. Which is, again, in the aesthetic realm, we always want to choose modalities that work. We always want to have things that we're comfortable using, but patients are paying for this. And so that is something you have to consider, right? You have to consider the total cost to the patient or to you and what your profit margin is as well. So I like these because they're low cost, and let's say like they're easy to place and just easy to manage.
And my other question is, how often do you do this without doing a blepharoplasty? I know I saw that gentleman, you didn't do a blepharoplasty in addition. Is that on purpose or cost, savings for the patient or just?
Yeah, that's a good question. I think it really depends, so looking at that malar projection, if somebody has sort of a zero vector, and we just want to add a little bit more augmentation, and they do have a significant amount of that steatoblepharon, I'm going to talk to them about doing the blepharoplasty. In the younger patients, I find I don't need to do it. Really, once we open it up and we dissect those planes, that fat just kind of settles down, and you really don't see it. So how often do we do it? I'd say probably half the time I'm doing a blepharoplasty with it, and the other half of the time I don't need to.
Interesting. And then I have a comment. I saw a patient once from Asia who came in with brow ptosis, but lo and behold, I found these temporal silicone implants that were actually the cause of the temporal hooding. So it had migrated all the way down to her orbital rim, and so that perplexed me.
Yeah.
But I can see the issue with facial aging, as Deepak had mentioned, with time, and they had been done, several, probably 30 years before, and now she's here in another country, and we're like, oh, lo and behold, they're in her orbit, superior orbit. So, just an interesting comment.
Yeah, but it goes to the concept that all the tissues change, the ligaments change, and where you place the implants and where you do the surgeries, those temporal implants subcutaneously they're not going to hold up. They're going to fall through. If you place something subperiosteally and you have that periosteum, that's one of the few structures that tends to hold up pretty well over time.
Yeah, I think we presented that patient for a visiting professor. It was interesting finding.
Excellent.
I have a quick question, Dr. Morrison. In the handful of patients that have done this, the results are beautiful, but there's one that I wish I would have picked a bigger implant. On patients that the patient is happy, right? So they're happy with it. But in the patients that I wish I had picked a bigger implant, what is the second way that I can augment that just little bit of volume left? Can I do fillers on top of it? Or how can I address that?
Right. So in patients like that, you do have the option of going back and replacing the implant. And any of us who've worked with silicone before, it forms a nice little capsule. It is not hard to go in, reopen that pocket, exchange the implant. It doesn't take long, very minimal pain. It's easy enough to do if you wanted to do that, and a relatively low cost because, again, the implants are very inexpensive. You can add fillers over this. However, what we tell patients are once you choose to do an implant, you need to remember you had an implant, and you need to tell the physician that you have that implant. Because typically the way I do fillers there is I go subperiosteal or preperiosteal. My needle's going all the way down. You don't want filler below this implant. That I can only imagine what kind of problems that would cause. And I've not done fat augmentation over it. Maybe Ramesh has and can comment on that. It's sort of in a submuscular plane. But the filler's done, I think, in our hands or people who are familiar with the implants, you could add a little bit of volume over top of it. Yeah. Great. Thank you so much.
Thank you, Ken. So our next speaker is going to be presenting virtually from Cabo because she had a family commitment. One of our co-chairs, Dr. Allison Watson, we're excited to still have her with us here virtually. She's going to be speaking on endoscopic mid-face lifting.
Hello, my name is Dr. Allison Watson, and I'm a member of the Oculoplastic and Orbital Surgery Service here at Wills. And I truly appreciate the pleasure to talk to you guys today about endoscopic mid-face lifting. And so sorry I can't be there in person, but I know that you guys are already having a great conference. We're going to start off by talking about the components of the aging face, and then we'll discuss why addressing mid-facial descent is essential to a great surgical outcome, particularly with lower lid rejuvenation. And then we'll talk about the technique for endoscopic mid-face lifting and what this technique is able to achieve cosmetically. So let's talk about the components of the aging face. We know that as we get older, the mid-facial tissues will start to deflate and descend. And so you have primarily this malar fat pad, which deflates over time as we get older, and then the influence of gravity ultimately pulls it down. And when that happens, this sort of downward sliding changes the overall architecture of the face and also sort of unveils the underlying ligaments and muscular structures that can cause the face to appear aged. And we know that this deflation process occurs over a number of years with all of the fat pads in the face, which, as you can see here in this schematic, as the patient goes from 35 to 55, there's substantial deflation, and this lack of volume makes the tissues more vulnerable to descending, and then of course exposure to gravity over time causes things to sink down. And the ultimate result of this is sort of this shift from the triangle of youth, so to speak, and this square of an aged face. And what happens is as the fat pad descends, you kind of lose this point of maximal projection within the visual axis, where the cheeks are at a more prominent and wider diameter than lower portion of the face. And as the mid-facial tissues descend, you sort of get a narrowing of the upper face and a widening of the lower face that results in more of this square. And so how does all of this fit in when we're evaluating a patient? So I thought that as we move through this presentation, we'll look at a patient of mine who underwent an endoscopic mid-facelift, so we can think about what types of things it can address and sort of break down all of these components of aging one by one. And so you can see that this patient, of course, has brow descent as well as redundant upper eyelid skin, but she also has descent of the malar fat pad, which has come down, causing weight on the nasolabial folds and a prominence of the nasolabial fold on both sides. But also this phenomenon of the malar fat pad descent results in sort of a lengthening of the lower eyelid as well. And as I mentioned, this unveiling of the orbital retaining ligament, which really results in this double convexity deformity with the descended malar fat pad as one elevation in the malar region, and then the sciatoblepharon of the lower lid above that orbital retaining ligament. And so when we think about how to sort of rejuvenate this person, of course she's looking for a periorbital improvement, but if we just remove this fat, we're going to leave her looking hollow. So how can we sort of integrate also a cosmetic rejuvenation in the mid-facial region to not only improve her overall outcome, but also have a more substantial and meaningful change in a positive direction from the standpoint of her eyelid surgery. And so here's just demonstrating, how this patient has gone to have this more square configuration as she's gotten older, with an almost equal diameter across the cheek area as she has along the lower face. So why is addressing the mid-face essential? So I just sort of alluded to this. If we put this patient's picture kind of side by side with the schematic that we were analyzing earlier, we sort of see this, right? We see the cheek fat pad with the separation from the eyelid fat pad that is very stark and visible, with a very apparent demarcation between the lower eyelid and the cheek. a lengthening of the lower eyelid, as I mentioned, and then of course the descent of the soft tissues. And so, as I mentioned, in order to really get this patient an adequate result in the eyelid area, we really can't ignore addressing the midface in her. And so that really then becomes essential. And so what are the problems that we seek to address surgically? Number one, of course, we want to address the fullness of the upper lids and the upper eyelid skin. Number two, we want to efface the orbital retaining ligament and address her prolapsed fat. Number three, we want to address the descent of her malar fat pads. And number four, we want to soften her prominent nasolabial folds. And so how do we achieve each of these things? So of course, the upper lid crowding is going to be addressed with a brow lift and blepharoplasty. The lower eyelid does require a blepharoplasty, but really also requires a mid-face lift to efface that transition from the lower eyelid to the cheek, and also requires volumization, right, restoration of that deflation, not just by upward repositioning of the malar fat, but also in her particular case, a transposition of that from the lower eyelid into the cheek. The malar fat pad repositioning is achieved with a mid-face lift, and softening of the nasolabial folds is achieved with a mid-face lift. So really we see that the majority of issues that she has in terms of not just her eyelids, but also her midface will all be kind of addressed in one foul swoop with a midface lift. And why is it valuable? Because it's able to address volume deflation and gravitational descent. So now let's talk a little bit about technique. The traditional way that I do this procedure is essentially as an extension of an endoscopic brow lift. So if the patient is having an endoscopic brow lift at the same time, which the vast majority of these patients are, because as you bring the midface up, you need to be cognizant of the risk of bunching in the temporal area if you're not going to elevate the brow. So that's really important to consider. But you really need to make this temporal brow incision so you can access the deep temporalis fascia and have a point for fixation. So you'll have your perimedian brow incisions as well as your temporal brow incision, and the temporal brow incision is going to be the workhorse for mid-face elevation, and your dissection will proceed down on the deep temporalis fascia, so you're in a safe deep plane away from the frontal branch of the facial nerve. You'll travel onto the zygomatic arch and get some subperiosteal release on that arch, staying within the medial third, again to avoid injury to facial nerve, and then you'll sort of move into mid-face and get substantial subperiosteal release all the way down to piriform with care taken to avoid injury to most certainly the infraorbital nerve or vascular bundle, but also avoiding injury to the zygomatic facial artery nerve as well if you can. And so one of the important points is also to release the soft tissues from the masseter cutaneous ligament so that you can ensure mobilization of the midface. Now, an alternative to doing that all endoscopically is to also make a gingival buccal sulcus incision, which can give you direct access to the maxillary, intermaxillary face, and you can do part of your subperiosteal release under direct visualization that way. So when we think about the zones of release, as I mentioned, you're oftentimes doing this in conjunction with a central brow lift in addition to your temporal elevation, but that first zone of release is going to be in order to elevate the temporal brow and gain access to the midface down to the zygomatic arch, and then you'll move into the midfacial tissues for that sort of second zone of release, and then or in this case, demarcated as a third. And then if you're doing a central forehead lift, also have the zone of release in the central forehead. But what you can see is the tissues you're going to be engaging in the midface here are then elevated in the superolateral vector that's directly perpendicular to the fullness of the nasolabial fold. And so really achieves a substantial elevation in that regard. And I included this figure just as a reminder of the importance of getting release from the masseter cutaneous ligament is very important for mobilization of the midface. So you want to make sure that that's achieved. You can do that under direct visualization with mouth incision, or of course with the endoscopic approach. And I found that often I really don't need to make that intraoral incision unless for some specific reason I can't gain access to visualize everything that I need to. In terms of fixation, there's lots of different ways to fixate. My personal preference is using the endotine ribbon, which is designed traditionally for jowl and neck lifting procedures. I like it because as opposed to the endotine midface, the designed instrument, this has multiple prongs for engagement that all will elevate in that vertical vector instead of just that one area where the tissue is going to be engaged. And of course, suture can be used as well. There's a number of different sutures that surgeons have described using for this elevation. So there's no really specific one that needs to be used. These are just two examples. And so here you can see just a schematic demonstrating the steps of engaging the soft tissue. So here's that temporal incision. This is with endotine ribbon being introduced along the deep temporalis fascia, being used to engage the midface. Then once the tissues are engaged, you can see that the instrument is on stretch, and you can see that cheek fat pad being pulled upwards in the desired vector, and then it is fixated. And here is just a video sort of demonstrating the placement. So here we have the introduction. It goes inside this sheath so that it doesn't engage tissues until the sheath is removed and is in the right position. And then once you have it adequately positioned, you can then take the sleeve off and then press down on the midfacial soft tissues in order to engage the endotine device. And then it can subsequently be fixated once you feel like the tissues are adequately engaged. And as you can see there, the mobilization is being achieved. And this video just sort of demonstrating a figure of 8 style suture, engaging the little eyelets of the ribbon and securing it to the deep temporalis fascia. Once this is achieved, then the superficial fascia is secured to the deep temporalis fascia as it would be for a brow lift. And here's just an example of a release that you get. This particular patient had an intraoral incision and an open cancel incision. She had like multiple previous brow lifts, so we needed some assistance in getting access to things for adequate release because of scar tissue from actually a couple previous brow lifts and a couple previous facelifts. So here's just a demonstration of the robust elevation you can get with release in these patients. And so what is the mid-facelift able to achieve? So this is our same patient before and after surgery. She had the endoscopic brow lift, a quadblepharoplasty with fat transposition, and an endoscopic mid-facelift. And we can really see kind of addressing all of those factors that we sought to address in the beginning. And I would argue that by using these multiple procedures to make a ton of small changes, we've made a really meaningful difference without causing her to look artificial, but with softening all of these abnormalities that made her look older to start. And most importantly, we were sort of able to reestablish that triangle of youth, right? We were able to elevate those malar fat pads to improve the size of projection so that she had, again, a broader kind of cheek diameter than was in the lower mid face. And so essentially, we were able to perform the endoscopic brow lift, a brow and forehead lift. You can see also some softening and lengthening in the glabellar area. So she did have a central release. She has a reduction in her lower eyelid length that we were able to achieve by bringing up the midface, and then has complete effacement of that kind of transition between her lower eyelid and cheek that existed previously, not only by adding volume through fat transposition, but also by elevating volume with the mid-face lift. Her malar fat pads, again, are elevated up to improve projection, and then we've also achieved some softening of her nasolabial folds. She's smiling in her after photo here, so it's a little challenging to appreciate that completely, but definitely did have some softening there. So I really can't advocate enough for thinking about how important addressing the brow and the midface are to cosmetic eyelid surgery. I think it really can elevate our results and give the patient a restoration of a more youthful appearance, and really take things to the next level. And so I think endoscopic mid-face lift is something important to consider as an adjunct to your surgery. So thank you so much for your time and attention. I hope you guys have an awesome rest of the conference, and thanks so much for having me, and miss seeing you in person. Take care.
Thanks so much, Dr. Watson. We have one question. Is there any risk of facial nerve branch paralysis? And of course, the answer to any facial procedure is yes, but particular areas where one has to be cautious about facial nerve injury in these procedures.
Sure. Hi, guys. I hope you can hear me. Deepak, feel free to answer this question for me if you guys can't. But
while we're sorting out the technical issues, I'll mention briefly, when you're doing an endoscopic mid-facelift, so essentially you can access the mid-face and the lower face through a temporal incision or a brow incision. Careful about, because you're in the pre-periosteal plane, is the zygomatic cutaneous ligament. So that is at the inferior lateral border of the zygoma, and the superior aspect of the muscle, and the origin of the zygomaticus major muscle from that area is a particular transition zone, because that ligament is so tight that if you don't, if you don't look out for it, then might be in the subsmass plane, and then it's easy to accidentally enter another plane, and then you can be in some structures where you don't want to be. So that in particular is the most risky area. And then as you go inferiorly, you have the buccal branches as well.
Can we get you on live? On live? Okay. We'll see if this actually works. We're going to have multi-modal virtual here. So I don't know if you heard the question. Yes, and how perhaps to avoid certain areas of concern.
Yes, I heard Deepak was beginning to answer that question. So I hope that I'm not repeating what he said, because I didn't quite get to hear his response. But the main areas of possible injury is, of course, when you're initially proceeding with the temporal dissection to gain access to the midface. You can potentially injure the frontal branch if you're not in a deep plane, adequately deep plane along the deep temporalis fascia with the initial dissection down towards the arch. And then I think one of the places that's most vulnerable, because in order to get your scope down into the midface, you do have to release along the arch a little bit in a subperiosteal plane. And of course, the frontal nerve branches passed over in the periosteal plane. They're deep there. So as you're moving laterally along the arch, there is a risk that you could injure it there. So I think staying in the medial third can really keep it safe. Of course, the buccal branches and zygomatic branches innervate the midfacial musculature deeply, but you're staying in a subperiosteal plane once you get in the midface. So I think that those are less at risk, but the main thing I think is kind of over the arch. So I think staying medially there keeps you safe.
Okay, excellent. Thank you so much. Excellent talk, by the way. Thanks for being with us virtually.
Thanks so much for having me. Have a great rest of the day, you guys. I'm sorry I couldn't be there.
That's quite all right. Any other questions for Dr. Watson while she's on? Okay, thanks so much, Houston. Take care, bye-bye. Good.
Great. Any other questions from anyone else here?
Any other questions for the panelists?
So let's take a 10-minute break and then we'll go into the eyelid section of the program, all right? Very good.
Okay, we're going to commence the second half of the program, the eyelid section. So I'd like to start this eyelid section off with Dr. Ned Bedrosian, one of our longtime attending surgeons here at Wills Eye Hospital and faculty member here. Thanks, Ned, for starting this off.
Well, thank you, Jackie, for inviting this talk to this symposium, which has been great so far. I welcome you that are here virtually as well. And we're going to switch gears a little bit and go into the eyelid. And in the next talk, first I'll say that these are my disclosures. None of them are relative to this talk. But we do want to consider some complications that are involved with blepharoplasty and ways that we can avoid them. We'll talk about pre-op evaluation, intraoperative potential complications, medical and technique oriented, as well as our post-op instructions to our patients. So some red flags for patient selection, of course, is beware of the dissatisfied patient. Either they're dissatisfied with a prior surgeon, they're dissatisfied with themselves in general. They may have some personality issues. And it's important for you really to inform them so they don't come back and tell you, well, you didn't tell me this, I'm misinformed. So this was earlier in my career when this lady wanted to have a higher lid crease. So I jumped in there and I did give her the higher lid crease, but she did notice that this little area on the right side was somewhat lower, and I didn't want to operate on her again for at least 6 months. And she must have called every 2 weeks or every 3 weeks complaining about the fact that she had this asymmetry. Sometimes we just have to say no. So this is another patient who came to me later in the career, recently actually in July of 21, saying that she had had 2 or 3 blepharoplasties. Her most recent one, she was dissatisfied. She took the stitches out herself. She was a dentist. And I was a little suspicious, and I suggested to her that she should massage her eyelid down. And I just wanted to buy a little bit of time. And I said, let's come on back in 6 weeks, and we'll get a look at her. So she comes back actually 6 months later, after she'd been to India for a couple times and had some surgery over there, looking like this. So I realized that there was something not quite right here, and I told her that she may need to get some counseling. I had to do this very gently, and she really didn't like that, and I kind of lost her to follow up. Later, fast forward to this week, she was actually presented in the VP rounds. So sometimes you just have to say no, and I'm happy that I did this time. All right, intraocular complications, particularly ocular, is the dreaded retrobulbar hemorrhage, which we'll talk about a little bit. We want to make sure we don't have any corneal injuries. And just a word about flash fires. We all know the triad of a fire. And remember to turn the oxygen off when you're using cautery. This actually did happen to me. This patient that was having a transconjunctival lower lid bleph, when even though the oxygen was off, she did get a flash fire, and she had a buttonhole through the lower lid. And you can see it left her with some pigmentation. Before we move on to technique relay, let's just discuss a couple of instruments. Of course, we can use the blade. We can use monopolar cautery for the incision and for the procedure, CO2 lasers, and radio frequency. The advantage of these are that they coagulate the blood as they cut, less bleeding time, less OR time. Studies show, however, that there can be damage thermally to the edges of the wound. Electrocautery has the most at 600 microns. CO2 laser in the continuous wave is 200 to 250 microns. The pulsed CO2 laser is less at 50 to 100 microns. And the radiosurgery or Elman is less at 10 to 20 microns. So here's a skin incision from blepharoplasty using a blade. Compare this to that using radio frequency, and we can see the thermal damage at the edges of the wound here. This is important only because in post-op, we may want to leave the stitches in a little bit longer to allow the wound to heal a little bit better. So let's move on to the intraocular potential complications based on the technique. Just like phacoemulsification for our general ophthalmologist out there, blepharoplasty is a series of discrete steps. The incision design, the injection of the anesthesia, the incision of the skin, the excision of the skin, the fat management, recreation of the lid crease if we're going to do that, and closure. And I want to walk through each one of these and outline some potential steps to each one. We have to know ahead of time whether the patient wants a low crease or they want a high crease. We want to have symmetry from one side to the other. And as we heard earlier, we want to have harmony from the upper face and the lower face. You don't want to give a real super tight blepharoplasty to someone that needs or doesn't want to have a facelift, and if they need it, or they need to have both blepharoplasty and a facelift. The female generally has a higher and a deeper crease. The male generally has a lower crease and it's more subtle. And there can be a lateral hood. And if that's the case, then we have to redesign the incision so that we get an upward and lateral direction at a 90-degree angle from the lateral aspect of the upper incision. So we first want to mark the inferior line, which becomes the site of the new lid crease. That's key. So in this diagram, we want to measure it at 10 millimeters, and we want to gently curve it above the punctum for about 4 millimeters and laterally at the lateral canthus about 4 millimeters. Then the upper line is marked based on the pinch technique, and we want to make sure that if there is less than 10 millimeters from that upper incision to the brow, then we have to consider a brow lift. So here's a patient with a lateral hood for which the design was adjusted, and post-op we see this result. Could have done a little more on that right lid probably. Some things that can happen, some issues we want to be concerned about is a double lid fold or a crease asymmetry, which we see here. We can also get a pseudo-epicanthal fold if the incision is carried too far medially. Lymphedema can be an issue. Recall that the upper eyelid laterally and the lower eyelid laterally both drain through the preauricular node. So if you have an upper and a lower lid blepharoplasty, you want to make sure that the incisions, when they're carried laterally, are at least 8 millimeters apart. Moving on to the injection, I like to use 50% solution of xylocaine with epi and marcaine for the long-term effect. The marcaine lasts about 4 hours. 30 gauge needle, 2 cc's into each lid. Some use white ace and sodium bicarb. I don't use either of those two. Some of the potential issues can be suboptimal pain relief, and certainly that's no fun for the patient nor the surgeon. Poor hemostasis from the decreased epi effect can lead to a subconjunctival hemorrhage as well as a subcutaneous hemorrhage, and of course, globe penetration from a misdirected needle. Moving on to the skin incision, if we have an unsteady hand, you can get a jagged incision, you can get canalicular laceration, and if you're using one of the electrocauteries or CO2 or radiofrequency, you can get a burn. Excision of the skin, primarily the main problem is with excess skin removal. You can get a lag ophthalmos and exposure keratopathy. This is an interesting patient of mine who was doing well in primary gaze, and actually when she raised her brow, there wasn't an issue. When she looked down, there wasn't an issue, but when she looked down and raised her eyebrow, she had elevation of that lid, and that's because too much skin was taken out. Other problems you can get is ectropia on the lower lid and lateral canthal dystopia. You want to make sure that the lower lid isn't lax, in which case you may need to do a lateral tarsal strip to tighten it. Fat management, the next step. This is probably the most important step in terms of reducing the potential of complications. We tend to clamp, historically cut the fat over the clamp, then cauterize it to reduce the risk for hemorrhage. This is where we would see a retrobulbar hemorrhage, the dreaded complication that can lead to loss of vision, or an orbital hematoma. You will recall that the eyelids are highly vascular, and these vessels run through the fat in the eyelid as well as into the orbit. So anterior traction on this fat during fat management can tear the intraorbital vessels and lead to bleeding within the confined space of the orbit, which, as you know, narrows posteriorly at the orbital apex. So sometimes you may want to be more gentle with the fat management, such as sculpting it with heat, where you can do a gridded pattern to shrink the fat back. Or if you actually wanted to take some out, maybe one of these other devices that coagulates that cut can help with the reduction of the retrobulbar hemorrhage. Now, Dr. Penny and Dr. Stefanishin reported this article of the incidence of post-blepharoplasty orbital hemorrhage following blepharoplasty, and they surveyed the ASOPers group, and they got 269,000 cases from 237 responses, and they came to the conclusion that the incidence of orbital hemorrhage after cosmetic surgery is 1 to 2,000 people. But the permanent visual loss, fortunately, was 1 out of 22,000 people. So it is relatively rare, but it can happen. And if it's going to happen, it'll happen usually within the first 24 hours, and especially within the first 3 hours after surgery. And if it's going to happen, it would be more common with patients that have hypertension, they're on perioperative pain management, such as aspirin or Motrin. They have some postoperative bleeding. They might have some postoperative vomiting, and they don't want to just chill out. They want to do stuff and get physically active. And this, I think, is a major problem, and we'll talk about that from complications in our post-op instructions. So in this top slide, you see from the orbital dissection course Will's eye has, you can see the fat compartments, and over here is the nose just for orientation. This would be the medial canthal area. If too much fat is taken out of the upper eyelid, we can get a deep superior sulcus. We can also get, right here is where the superior oblique would be. So if we're managing the medial fat pad, we can get a superior oblique palsy. In the lower lid, we see right here the inferior oblique muscle between the nasal and the central compartment of the medial fat pad. Here's the temporal fat pad over there. We can also get an inferior rectus palsy because the inferior rectus and the oblique are very close together. So here's a lady that's 6 weeks post-bleph, and she has this deep superior sulcus from too much fat that's been removed. We can also get injury to the levator. In this surgical slide, you can see how close the central fat pad is here at the pointer to the white glistening levator aponeurosis there. The next step is the recreation of the lid crease. This is a very important step if we want a deep and a high lid crease. It's done by first taking a pass through the lower skin edge, grabbing a little bit of the levator aponeurosis, and then again through the skin of the upper edge. This pass should be no more than 1 or 2 millimeters superior to the superior edge of the tarsus. Problems with this could be asymmetry of the lid crease. You can get variation of the depth of the fold as well. You can get retraction of the eyelid if the supratarsal fixation is too low. That in effect raises the eyelid. And this is a patient that was sent to me from a facial plastic surgeon who actually caught the orbital septum, which is another potential. Fortunately, we were able to reduce that. You can also get ptosis if you have about too high supratarsal fixation, and that's because that suture acts like a splint and it prevents the lid from moving up. And also you can get it from damage to the levator itself. Finally, the skin closure. The most important thing about skin closure is that you have to make sure that your incision site is absolutely dry and you have complete hemostasis. I like to use 6-0 nylon because it's less reactive. You can get unsightly scars or suture tunnels. You can also get some epithelial cysts. Now, the post-op instructions are mainly designed to reduce the risk of post-operative hemorrhage, and that's mainly ice compresses every 2 hours, no aspirin, no NSAIDs, no alcohol, no hot beverages because heat can dilate your blood vessels, and by all means, avoid Valsalva. Sutures are usually out in 7 days, sometimes 10 if I use a CO2 laser or the radio frequency. So here's a lady that had a four-lid bleph, and she was out gardening. This is 2 weeks afterwards. She developed this subcutaneous hematoma. So beware that bleeding can occur even longer than just the 24 hours, which has been suggested. And this is a patient that was sent to me by actually a dermatologist that did a transconjunctival bleph, and he developed this subconjunctival hemorrhage 2 days after the procedure, after he had this violent episode of sneezing. So in summary, to avoid complications or to reduce them, preoperatively, sometimes we just have to say no. That's really a hard thing to do. Intraoperatively, be meticulous about each step of your incision all the way through to the post-op closure. Each one of these steps can have potentials for problems. And post-operatively, instill on your patients the importance of compliance and to just chill out for a week or so until the risk for a hemorrhage is a lot less. So this is a patient that I had done a four-lid blepharoplasty 1 day post-op with a normal amount of post-op edema and ecchymosis. And I just present this to you because she came in with her husband, totally unrelated to this case or to this presentation, but he came in with a subconjunctival hemorrhage. So about cosmetic surgery, Byron Smith, in closing, the late Byron Smith, said that if you're not sued 3 times a year, then you are not doing enough surgery. Thank you very much.
That was a great talk, Ned. In my fellowship, I was taught that the best cautery is to stick a 4x4 on it and do the other side and ignore the active bleeding. So I appreciate your attention to hemostasis. We do have a question about if you do any, or if you have any specific protocol for how long you like people to be off their anticoagulants before or perioperatively when you have them restarted.
Yeah, that's a really good point because each anticoagulant has a different time frame. And even if you go by the rules of what they say, I generally like to try and keep people off any anticoagulant, regardless of what it is, for at least 2 weeks if they can do it. And that is really generally guided through by their family practitioner that has put them on the anticoagulant, just to make sure they don't have any cardiac problems for that. The other thing about that is that I also ask patients, and this is probably the worst part of their pre-op care, particularly patients that do this, I ask them to avoid not only aspirin and NSAIDs, but I also ask them to stop garlic, ginger, ginseng, ginkgo. So anybody that likes Italian food or Asian food, they have issues with that. Also, anything with a G, G times 4. So, and we have a whole list, and I'm sure lots of us do in our office of things that they should be avoiding or, being careful of.
Are you using tranexamic acid?
I personally am not using it, but that is something that I know lots of us in ACE hoppers have had great success with. Are you using it?
I'm putting it in my tumescent for brow lipo face, but I'm not using it for straight lid cases. I know there's some mixed evidence on whether or not it helps. I think that for cases in which delayed hematoma is a problem, like for example, if you have a big skin flap from a Mohs closure or something, the TXA prevents the clots from falling off. It doesn't prevent you from bleeding during surgery. It prevents the clots that have formed from falling off 5 to 7 days later. So in those situations, I find it to be more helpful, which is why I use it. But
great
questions now, or is there going to be
let's take some questions now.
Yeah, great talk.
Thank you.
I really appreciate
Let me give you a microphone.
the
secondly, you remind me as a oculoplastic fellowship trained why I didn't like cosmetic surgery. But here's the thing. When you're taking out the fat, and I agree, that's the most important step, is there a science to it, or is it all art? How do we say good results come from experience comes from bad results. Is it just a matter of learning a touch, a feel, an art, or is there something more to it?
Yeah, it's all of the above, all of everything you said. I think that historically in the past, we would be more aggressive with fat removal. I think from our lectures earlier this morning, we learned that as we age, we tend to absorb that fat anyway. So if you're dealing with a person in their 30s or their 40s, you really want to be careful and conservative with what you do in terms of taking fat out. And I tend to like to just shrink it back so that it's level with the septum, or it's level with the anterorbital rim, or doing the lower lid, it's level with the infraorbital rim. And if you kind of have to discuss that with the patient ahead of time too, to see whether they're bothered by the bags or they're bothered by the infraorbital rim or the supraorbital rim that's showing. And I think the better statement right now is to say less is better. Yeah.
People have tried to answer your question scientifically. So there's a 3D camera that Canfield makes called the Vectra. People have tried to use that, and they also sell this face morphing software to see in 3D volumetrically how much lower lid fat do I need to remove. They use the software to come up with some number, 2.5 cc's, and then they take the fat out and they put in a syringe and do 2.5 cc's. And what we find, or what those authors found, and clinically I think what all of us find, is that fat is compressible, fat moves around. Where you see the fat preoperatively is not where the fat is going to lay postoperatively, because you've released a lot of those fascial septa. So it doesn't really correlate well to what you think you might need to remove, using that kind of software.
For the three of you, I used to use radio frequency. How do you choose which of the ablators to use?
If the patient is on anticoagulants, or I know that they like to eat a lot of garlic, ginger, and ginseng and that kind of thing, and I'm kind of suspicious that I might have bleeding afterwards, I will use the radio frequency. I have one in my office, or I'll use a CO2 laser, which I have in my office. I actually like the CO2 laser better than the radio frequency because it tends to coagulate a little bit better. But the radio frequency is really nice as well.
Thank you.
I use a blade for my incision. I don't like to scorch the earth. I have a no scorch earth policy. So, and then I do cautery. I don't use Bovie cautery. I use bipolar cautery to basically clamp the fat, cauterize, and then cut. Special consideration medially, because the medial fat pad often has a larger vessel in that area. And I've had 2 orbital hemorrhages requiring canthotomy, canthelysis, the whole works, from upper lid blepharoplasty, ptosis repair. Usually more common in the lower lid, but I've had it 2 times in the upper lid, thankfully with no vision loss, but had to be treated. So I'm just very cautious in that area. I tend to do very little fat removal in the upper lid, just medially, to shrink it or take it away. Just like Ned said, just shrink it with the bipolar cautery superiorly.
Your point about the nasal fat pad is much more vascular than the preoptic or the central fat pad, because the dorsal nasal artery comes forward medially in the orbit. So if you're addressing the medial orbital fat pad of the upper lid, you really do have to be careful and meticulous about making sure that there's no bleeding when you're
Be very cautious. I've had arterial bleeds in that area, so very cautious there.
I mean, we did in fact see a case of, no light perception vision from a community surgeon, a month or 2 ago here. So it is a real thing. And, I think probably the best thing that you should do is make yourself accessible to your patients so they can text you a photo, an hour after they go home, so you know what's going on if they say I'm bleeding, because you can't really tell on the phone.
Yeah, that's actually a good point, Ramesh, because I tell my patients, if you're having severe pain, if you're having sudden loss of vision, more so than what you have now, and you see a lot of swelling or proptosis, call me. I don't care if it's 2 o'clock in the morning. I don't care if it's 3 o'clock in the morning. You call me, because it's so important that you catch something and address this within the first 24 hours if they have some kind of an issue. Fortunately, it's never happened to me. In that situation, I've been an expert witness and as for other lawsuits on it, but it is really, really critical that the patients listen to what you're telling them. If you don't think they're going to be compliant with what you're telling them, then don't operate on them.
And I think what Deepak said about sending a photo, because patients can call very upset that they're bleeding, and then you look at them and they're beautiful, like their eyelids are open. So I also say, like a picture's worth 1,000 words. But I tell patients that I don't anticipate severe pain, excruciating pain. I don't anticipate the eyelids swelling shut where you can't open them to see. I think vision loss is a little bit sketchy because of the ointment, and everybody is going to be freaking out about, my vision's lost. But yes, obviously if they can't see. But I think those two things, if you can't open the eyelid to see enough, then there's a significant amount of swelling and or severe pain.
One last question for you, Ned. Question from the audience. So how do you prevent lateral extension of the scar in upper blepharoplasty?
How do you prevent lateral extension of the scar of the blepharoplasty?
Or how do you prevent that thicker temple skin if you extend your upper blepharoplasty incision out from scarring so noticeably compared to the thinner eyelid skin?
If it's an elderly patient and you have deeper lines or creases out there, sometimes you'll have to take either a little more skin, but make sure your incision is in a natural lid crease. And within 3 months to 6 months, that scar usually blends in. If you cross that line of a natural longer line crease, then you may see that. If your incision is jagged, you may see that. So it's important you have a smooth, consistent incision. And like Dr. Krasko, when I incise the skin, I use a blade. I don't use a laser for that. Okay, because the laser does create a little more scar at the incision site.
I also add, if you have a lot of lateral hooding, you should do a brow lift probably.
Correct. Well, that's key too. So if your incision is so close to your brow, they probably need a brow.
Yeah, they say if you go past the lateral canthus with your upper lid incision, there's probably a component of brow ptosis that you need to address.
Exactly.
Very good.
All right, great discussion. Thank you for your attention.
So we have Dr. Krasko talking about cosmetic lower eyelid blepharoplasty, the ins and outs. Thank you so much, Dr. Krasko.
Thank you, Deepak. Thanks for having us today. This is a great talk, great conference. So we'll talk about lower lid blepharoplasty at this point. So no relevant financial disclosures. I may be discussing off-label uses for injectables, botulinum toxins, hyaluronic acid fillers, and hyaluronidase. So as we've discussed in multiple lectures today, that the eyes are the focal point of the face. They're the emotional center. We see them aging first on the face, not to mention, the mid-face and lower facial considerations that we've discussed already. The eyelid skin is thinnest in the body, subject to constant motion. You blink about 20 times a minute. We lose elasticity, as we've discussed. There's atrophy of the subcutaneous facial fat and gravity, as well as photo damage from sun exposure. And our orbital septum thins with this pseudo herniation of the fat anteriorly. And then we have this demarcation of the orbital retaining ligament to demarcate the eyelid from the cheek. And so I thought these were beautiful sketches from our own Dr. Jeff McMahon, who's an ophthalmologist here at Wills Eye Hospital, showing a youthful eyelid, which is quite full, versus an aged eyelid where you see lots of shadowing and lots of redundant skin and tissue, mostly from the fat atrophy. And Dr. Watson talked about the aging midface, but our midface aging does elongate the lower eyelid. There's descent and atrophy of the midface fat, which leaves, we know, hollow along the orbital rim, which creates this double convexity deformity. And that creates prominent nasojugal and nasolabial folds as our midface continues to age. So as our SOOF descends, we discussed before, our orbicularis weakens. This leads to malar bags, festooning, and deficient tissue at the orbital rim with this pseudo herniation of the orbital fat and this double convexity. So a youthful eyelid is a smooth, sweeping eyelid where you can't see where the eyelid ends and the cheek begins. An aged eyelid is a definite demarcation thanks to that orbital retaining ligament, which separates these fat compartments, and you get this double convexity deformity. So I like to think of it simply, when we're born, we're nice and full of air like a beach ball, and then as time goes on, we start to lose air, and we get these little ripples in our face, our wrinkles from deflation. So when we talk about lower lid rejuvenation, there's certainly some non-surgical options. Most eventually go to surgical options at some point, and we'll talk about our 4 steps. But for the skin, we have to discuss, there's retinoids, there's hydroquinone, which is very difficult to find lately, as the FDA pulled it. Chemical peels, there's lasers that can be done. You have to, pay attention to the skin. The dark circles, typically, we see not so much pigment there, but the contour of the orbital rim, which is visible. So a hollowing along that orbital rim. And then filler injections along the rim are exceedingly popular and kind of like a nice foray into getting into blepharoplasty, perhaps a start point for someone in their 30s or 40s with good skin turgor that you may want to hold off on a blepharoplasty. I like thinner size filler that's less cross-linked so that it's not very hydrophilic, and we don't want lumps or bumps in that area. It's a tricky area. So surgically, cosmetic blepharoplasty, the lower lid, I think of 4 steps to address the fat or lack of it, the orbital malar ligament, the skin, and then the lateral canthus / orbicularis soup suspension. So when we analyze a patient looking at their lower lids for rejuvenation, we look at their skin. Is it redundant, crepey? Are there fine rhytids? Is there lots of skin or actually lack of skin, like in this patient? Look at the orbicularis oculi. Do they have festoons? Is it really extending down into their midface? Look at the fat or lack of it. This patient doesn't seem to have a lot of fat to her lower lid. Is there laxity of this lower lid? And like in this patient, we have to be aware of something called a negative vector, where their eye is more proptotic compared to their cheek. Their cornea is in front of their cheek. And so these patients are more at risk for postoperative complications like ectropion, as you see here, with lower scleral show. So those all have to be evaluated. So we like to blend aesthetics and function, and just know that surgical rejuvenation goes through trends, and sometimes more causing extensive maneuvers and causing more complications. But recent techniques, I think we try to keep it simple. Focus on complication prevention. I say a happy eye is typically a happy patient. We don't want to make them miserable or into a medical patient postoperatively. So I think if we consider doing a canthopexy, minimal fat removal, minimal skin removal, and enhance that lower lid cheek shape, you're going to be in good stay. So we talked about this before, about the orbital prolapse fat, anterior prolapse fat restricted by the septum attached to the rim, and this orbital retaining ligament, and the cheek fat descends. So we start to see this aging eyelid. Where is this SOOF? It is below the orbital rim. It's this malar fat, more extensive laterally over the zygoma. And it's more fibrous fat than, like the orbital fat. You can definitely see a difference there. And it's analogous to the SMAS. So when you pull on it, it actually helps to tighten the whole eyelid and the whole, orbicularis, similar to what you do with facelifting and tightening the SMAS. I say the SOOF is that analog. So no talk is, lower lid talk is complete without tear trough deformity, and I think Dr. Morgenstern did a great job about that. Maybe this candidate would be a great candidate for his implants. But this nasojugal groove, it's medial along the inferior orbital rim and more prominent as we age, with loss of fat over the orbital rim. So you have to take care and look at that. It is a distinct cutaneous groove. It extends inferior lateral from the medial canthus to the medial pupil, and laterally it's called the palpebral malar groove. And as you advance aging, the grooves connect, to form a whole lid cheek junction. And this area is a true osteocutaneous ligament found from the maxilla to insert on the skin and orbicularis continuous as the orbital malar or orbicularis retaining ligament, which we've discussed lots today. So lower blepharoplasty, what are your options? There's the transcutaneous, which is the outs, the transconjunctival, the ins, or my preferred technique is transconjunctival with a skin pinch, kind of like an in and out blepharoplasty. I should trademark that, in and out blepharoplasty. But reposition, remove or graft fat, that's an option along the rim. Do you cover the rim with fat, which I don't do this anymore, but transpose fat. And what do you do to the skin? Do you excise the skin, ablate the skin, chemical peels, lasers, etc.? And not for everybody, but I think it's an interesting thought to release the orbital malar ligament to create the smooth eyelid cheek continuum, which I like to do in some patients. So operative risks, we've discussed ectropion. You don't want to have patients with lag ophthalmos from too much skin removal. This patient more has laxity afterwards. You don't want to create inferior scleral show with dry eyes. Chemosis occurs about 10% of the time. Again, sometimes from that lymphedema from the lateral incision. Asymmetry, of course, is possible lateral canthal rounding and scarring. I find this more commonly seen with transcutaneous approach because you are actually cutting right through the septum and that middle lamella. Of course, you can have swelling or lumpiness where the fat is repositioned or grafted. So, we've had a paradigm shift from old intraoperative planning, maximal muscle resection, emphasis on fat removal, a long-term hollowed appearance. And so I hope we've discussed this today, that we try to avoid that with proper pre-op analysis. We try to preserve the orbicularis oculi muscle. I say there, a good orbicularis is your friend. After surgery, we want the patients to blink appropriately and shift really towards eyelid shaping and periorbital contouring, blending that eyelid cheek junction to create a natural and fuller lower eyelid. So there's twofold goals of blepharoplasty, both the aesthetic, where we want to make that smooth continuum between the eyelid and cheek with reduced appearance of the tear trough and nasojugal fold and loss of redundant skin or improved texture of the skin, which is important adjunct. Functionally, especially as oculoplastic surgeons, we want to prevent lid malposition, reduce scleral show, and maintain that lateral canthal angle and support of the eyelid. Very important, especially in our patients and our ophthalmology age range of patients. So Dr. Rorik, I think I like him because he keeps things simple. He's spoken at the ASOPRS conference, excellent facial plastic surgeon, general plastic surgeon in Dallas. Dr. Joa had described some of his techniques earlier. He describes a 5-step bleph, and aesthetic outcomes in lower lid blepharoplasty can be improved when addressing anatomy. He describes supportive deep malar fat compartment, augmented usually with fat transfer. Lower lid orbicularis oculi preserved with minimal fat removal. 3, the orbicularis retaining ligament is selectively released. 4, lateral canthal support strengthened, and 5, minimal skin is removed. And I agree with all of those, but I've even simplified it a little bit more to 4 steps: fat or lack of it, the orbital malar ligament, skin, and then the lateral canthal fixation / suspension. So my preferred technique, we'll discuss the transconjunctival with skin pinch and selective OML release. So 4 steps to the lower lid bleph. The transconj entry to the fat: 1, preserve the fat, especially medially. There's less fat in the lower lid. In the upper lid, I tend to remove the medial fat pad selectively, but lower lid, I preserve the fat, especially medially. Remove fat as necessary, and that's more the art of it. I actually almost like the patient a little concave when I'm finishing a blepharoplasty. I'll press on the globe, and that's basically what they're going to look like when they sit up. There's going to be a little more prolapse. If you've noticed, your patients look great when they lay flat. All the fat kind of goes back and they look wonderful, but that's not how people see them or they see themselves. So you have to kind of be one step ahead. Remove fat as necessary, not too much. Orbital malar release, skin pinch, and then a chemical peel. You could do lasers, and then the lateral canthopexy / SUV tightening. So I like to mark the patients preoperatively, sit them up, as I said, and because when they lay flat, everything improves. So this is just a sped up transconjunctival approach. Pearl silk at the margin, and then transconjunctival, and then I'm opening up the fat pockets, the 3 fat pockets with Stephen scissors. Just like to kind of free up all the fat to see what we're dealing with. This is on a GoPro. So here we talked about fat removal. So I kind of will cauterize the base with bipolar cautery. You see me doing that. Lift it up, cauterize the base. And I don't remove the whole fat pad at a time. I kind of do it in a graded approach and then take a look at the lid. So here's me taking some skin, subciliary, extending it laterally. And then I do this canthopexy. This gives me access to the lateral canthus. And again, I'm not cutting the canthus. I'm just basically taking a 5.0 PDS and taking that pretarsal tissue right to the orbital rim for a canthopexy. There we go, taking a look. And then I'm releasing and dissecting down to just get to that lateral SUF. It's still attached to the orbicularis. You take a nice juicy bite here, laterally. And it's important to be a little bit more lateral. If you're too medial, you can actually tighten the lid too much. But this obviates me needing to remove a good amount of skin. And so we take a little mattress suture here and down to periosteum. And I tie this, and it should pretty much just come naturally. I'm not bunch the upper lid, and then I'm just putting a interrupted suture right at that area to the skin, and then we'll close the skin. So when we address the fat, again, minimal fat removal, consider partial removal at a time. And I reserve fat transposition or fat transfer to deeply hollowed tear trough. I find fat transposition, I used to do it for everybody, and I find it difficult in my hands. I don't know how many of you fat transpose, but I find it a little unpredictable, and most patients don't like the little puffiness, especially if they have thin skin. It's just really difficult. Not to mention granulomas from sutures and other things. But I do like the fat transfer, not for everybody. I know some others, I know defect, you like fat transfer for everybody, but I personally reserve for negative factor or fat deficient or hollow patients. So this is a patient, four-lid blepharoplasty before a daughter's wedding coming up. But again, I just felt that she was quite hollow, and we did fat transposition to the rim and cheeks and upper lids. With a very nice postoperative result. So this transconch fat sculpting, I do this 4L silk at the margin, just go in a systematic way. And conge and lower lid retractors are incised. And then again, we saw the Stephen scissors to release the fat pockets. So this is on probably everybody's boards at some point, ophthalmology boards, a picture with like an arrow in this area between fat pockets. And that's our inferior oblique we want to identify and void throughout the procedure. So step 2, selective release of the orbital malar ligament. In this bottom photo, you can just kind of see how we go down pre-periosteally to get to that anterior rim, similar to Dr. Morgenstern's discussion, but this is pre-periosteal. It's selectively released to basically you're lifting up a flap of orbicularis and skin. The whole eyelid can just release. This is not the arcus marginalis, so this is not the septum. That's a periosteal adhesion. So here's the orbital malar ligament release. And again, I don't do this, I don't think there's one surgery for every one patient, but we're going anterior to the rim in this. I do it with Stephen scissors. I like to inject this area with local because it can bleed, just FYI. So we go down anterior to the rim, and I don't do the entire rim, just the tear trough area. I find that this causes less issues with the lower lid. So step 3, address the skin. And most, you'll find a little bit of skin on the lower lid is a big deal. So most need minimal skin excision. I do it subciliary, conservation of the orbicularis in this area. I tend not to cauterize the orbicularis. I find that's helpful for postoperative healing and blinking and functionality of the lower lid. Very, concerned with that. And when you tighten that orbicularis and the lateral SUF, you really obviate the need for lots of skin removal for a healthier eye. So then we'll do a chemical peel. Of course, you could laser the skin. we're getting to it somewhere here. So patient, of course, Fitzpatrick, 1 to 3, you'd want to do this on. Most of my patients, who need this, lots of actinic changes, are the skin color. And so you can put it all periorbitally with 40% TCA. And what you want to see is basically like a whitening of the skin. You're starting to see that here. And just trying to smooth and feather this from the eyelid to the cheek. That's the TCA peel. So step 4, lateral canthal fixation. We discussed a little bit, and I think this is key to preventing post-operative malposition. I'm not trying to change the shape of the eyelid. I think when you do a canthotomy and cantholysis, and of course we do that for patients who are really lax, but for this, we don't want to change patients' shape of the eyelids. I think that's a big concern for most patients. But we basically put the eyelid where it should be, and when you tighten it, it just almost rejuvenates the lid. And not to mention, I think it's healthy for the eye, for the lid to be a little tighter. So it avoids asymmetrical canthal angles. We don't just let the canthus fly. We actually fixate it and put it wherever we want it. And again, of course, you can do a canthotomy if it's moderate to severe laxity, if you have to shorten the eyelid. Good. And the next one. So SOOF orbicularis suspension, I showed you the dissection earlier, but we're basically taking a nice healthy bite of the SOOF, which is this lateral fat, it's past the lateral canthus. And you can always, when you pull it, you see the whole eyelid tightening. So, and we suture this, this is on the outside of the rim, the canthopexy is on the inside of the rim, periosteal bite, this is on the outside of the rim. And it creates like this orbicular sling, similar to a mass tightening for the face. And then when you tighten it, you just want it to basically be not lumpy, bumpy, or traction. It should come together nicely. And sometimes I'll just grab a little orbicularis in that suture tightening for it to come together. So, patients can have nice results. Some of these patients, you may say, well, maybe we could do, fat transposition for some of these patients, but that does add a layer of complexity and, cost to the patients. And most are happy with the 4 steps, upper and lower lids, male blepharoplasty, upper and lower lids, lower lids plus little browpexy. Before and afters, ptosis repair. So in summary, I like simplified but not standard. My lower lid blepharoplasty continues to evolve. Every time I give a different talk, it continues to evolve. And I think if you think of 4 steps, transconjunctival approach to fat sculpting, plus or minus fat to the rim or cheek, the orbital malar ligament release, which I think is optional, not standardized for everybody, skin pinch, and then a canthopexy orbicularis SOOF resuspension really helps maintain a healthy eye with good cosmesis. Thank you. As my husband said, these are my 3 children here.
So we have one question from the audience so far. What is the major advantage of OML release?
So I don't think you need it for everybody, but if it's a really, and I've stopped doing it for everybody because sometimes I actually will take my Steven scissors and try to release, and it's already very loose already. But for patients who have a really demarcated trough, a tear trough, I think it's helpful, and it elevates the lid. It's almost like you're elevating a flap, you're like undermining it, and it gives you a little more elevation and lift. Any other questions?
I have one question.
Sure.
I find the hardest part of this surgery, if you're doing a skin pinch, is to know how much skin to take out. How do you measure that? Are you pinching? Are you elevating? And then, how do you do it?
So I start with just basically a couple millimeters, maybe 3 millimeters, a little crease on the lower lid. I actually don't measure it. I measure very cautiously on the upper lid, but in the lower lid, I basically make that little, let's see if I have a picture of that somewhere, but I can show you, basically subciliary, I extend a little bit laterally. And then we start with that. And I just want the skin not to override the margin. I want it to come right together with the, right underneath the lashes. When I reserve removing more skin after I tighten the orbicularis and SOOF. And you want just the right amount, which is, easy to say, hard to do. But, I start small and then I take little slivers if I need more. I'm just very cautious with the amount of skin on the lower lid. You can easily take too much.
I do have a question.
Sure.
If you have the medial fat pad atrophy over time and you don't transfer fat, what do you do?
So I will remove some of the medial fat pad. I'll release that orbital malar ligament. Sometimes I extend my medial incision of my skin incision, and that helps to elevate that medial area and kind of, you just don't want to see the tear trough as prominent. I don't tend to transpose. I've had issues with people I've had too many issues with people saying, what's all this fat? I don't think people want to wake up and have puffy eyelids. And so I think the lack of fat is almost easier to tolerate than too much fat. And as much as we like to preserve fat, I think that's difficult to do long-term as our skin is thin and everything shows through that. But I'll transpose fat in that area. If I really feel that there's a deficiency or hollow and patients are amenable to it, I don't make it, standard with my surgeries. It's like an add-on, but I do like the fat transposition as long as you stay deep. And Dr. Shabako is going to discuss fat transposition as well. Fat transfer.
I think Dr. Bedrosian had a tip on skin.
Oh, please.
removal.
Yeah, if we're doing a transconjunctival blepharoplasty and we want to know how much skin to take off with the pinch technique, that's exactly what I'll do. I'll add some forceps and I'll lay it down next to the cilia with it open, and then I just push down with the forceps so it's parallel with the skin opened, and then I close it. And the amount of tissue that's within that pinch, I do that. I move those forceps from medial to laterally so that I get this pinch all the way across, and then I excise it at the base of the pinch.
I think that's very safe, classic way. Another classic way of doing it, but a lot of my patients are under, deep sedation or general anesthesia. But I know in my fellowship, we'd have the patient look all the way up and open their mouth, and that's the maximum amount of skin you can actually take away.
I think, that's probably the most risky part of the whole surgery is what you do with the anterior lamella. So just, start slow, and you can always take off more skin if you need to, but you can't put it back. So
very true. And I think fixating the lid also helps. If let's say you took a little much, at least you fixated the lid and it's not going to pull down. Good. Great, thank you.
So we've got Dr. Shabaklo now talking about fat grafting to the periorbital area.
Good morning, everyone. My name is Karine Shabaklo. I'm the Wills Oculoplastic Fellow here. I work with the oculoplastic surgeons of Philadelphia, particularly Dr. Carrasco, who just spoke, and Dr. Watson, who spoke earlier today. What I'd like to talk about is eyelid and periorbital fat augmentation. We've seen the different approaches to the lower eyelid blepharoplasty and facial implants that Dr. Morgenstern discussed. And I would like to just add a little bit to this discussion to just point out some other approaches of how we can use our own fat, taking from elsewhere and moving it to the face and to the periorbital region. We'll start with a short introduction on what it means to do autologous fat harvesting and grafting, the anatomy of the eyelid and the periorbital region. We'll talk about the aging face, and I think all the participants today will now be mini experts on the anatomy of the aging face, because we've looked at it from so many different approaches, from the eyelid to the midface and then also to the jaw contour. The technique of facial grafting, facial fat grafting will also be discussed, as well as our results and outcomes, considerations for the oculoplastic surgeon, complications that should be noted and avoided, and finally some concluding remarks and thoughts for the future. I'd also really urge you all, if you are interested in fat grafting, a great resource is actually Dr. Ramesh's two-part ASOPers podcast that was released just about a month or so ago. And this was a great resource for me, both as a fellow and also in preparing this talk. We've mentioned today a few times about the different approaches to the lower eyelid blepharoplasty, and I'd like to point your attention to a few considerations. We started off with the transcutaneous approach in the early days of oculoplastic surgery. This was the traditional paradigm of eyelid surgery that was subtracted. So we took tissue away. It was focused mainly on excision of fat and maximal skin that could be taken while still allowing adequate eyelid closure. And from there, we've moved to develop multiple canthal suspension techniques, as Dr. Carrasco mentioned, to prevent eyelid retraction and atropion. And these are the complications that were noted by some surgeons, and for that reason, many oculoplastic surgeons and facial plastic surgeons have moved towards the transconjunctival approach. It was first described in 1924, and then it came back, was reintroduced, returned to vogue 50 years later, and this was a second skin incision that allowed skin excision, but without violation of the orbital septum and the orbicularis. And finally, in the 1990s, we've started to talk and focus our attention to recognition of the role of volume loss in the aging face. So it's not just gravity and laxity, it is bone resorption and volume loss due to fat loss. And now we are more focused on the prevention of volume depletion. What I would like to know is that really, as surgeons, we're not just doing one of these techniques. We're taking a little bit here and adding a little bit there. One of the lectures that I listened to was you have to rob from Peter to give to Paul. And so I urge you to think about that this is really a multimodal and multifaceted approach. The goal of aesthetic surgery is to maintain the appearance of a youthful eyelid. You want patients to appear full, devoid of skin laxity, and have as few rhytids as possible. And this paradigm shift was used to help us understand that we're trying to efface the depressions related to aging and to improve the contour of the eyelid and the adjacent structures. And by that, we will focus on two techniques. Dr. Carrasco discussed the transposition of the native eyelid fat, and I will talk about harvesting and fat transfer from a secondary site on the body and bringing it into the periorbital and midface region. The anatomy of the periorbita is what makes what we do so important and so unique, because there are important landmarks to note, but eyelid anatomy, although such a small area on the body, is actually a very complex area, especially when it comes to aesthetic considerations. We're all ophthalmologists for the most part here, so I will touch just briefly on this, but moving anterior to posterior, we move from skin to the orbicularis, which is the primary protractor of the eyelid. It helps maintain eyelid strength and tone. And then the septum. The septum is an important thing to note because it is the connective tissue rising from the arcus marginalis that adheres to the periosteum at the orbital rim. It fuses with the lower lid retractors and the levator aponeurosis. And issues with the septum can lead to complications such as ectropion and lower eyelid retraction. And finally, the orbital fat that we have mostly sought to focus on removing and transposing in prior lectures. The eyelid fats, just to remind you, you have the 2 fat pads of the upper eyelid and the 3 fat pads of the lower eyelid. But I do want to draw your attention to note that the eyelid fat pads, while they are sitting a little bit more anteriorly, they are contiguous with orbital fat pads. And Dr. Bedrosian mentioned some complications that can arise by putting too much forward traction. Now moving into considerations for the midface and the cheek. So the lower eyelid to the oral commissure, we need to remind ourselves to draw our attention to when evaluating our patients. JP and JP, my co-fellow, always jokes that we like to focus on the eyelids because we're trained as ophthalmologists, and with the usage of masks, we now tell our patients, please take your mask off because we need to make sure that we are not missing this important aesthetic component. The zygomaxillary apex was described by Dr. Masri and Dr. Azizadeh. It's also called the OG point, and this is the area of maximal projection. When you see photos in social media of young, youthful, beautiful actresses, you will see that there is this area of maximal projection. This is drawn by bringing a vertical line down from the lateral canthus or vertically downward, and then horizontally a line coming from the apex of the nose all the way back to the anterior part of the tragus. And when you're thinking about where you want to revolumize the female face, you need to understand this area. And the red star here explains where the zygomaxillary apex is, and trying to have a little area of a triangle that will allow you to transfer fat into that area. Dr. Watson discussed this a little bit earlier, but remembering that the inverted triangle of beauty, we start in our 20s looking like this, and as we move into the 50s, 60s, and 70s beyond, we become more square-like, and that is due to laxity, but also due to gravity. And so what I really want you to pay attention to in the photo on the right is that there is less volume in the upper face and more of the volume in the lower face. And what that really highlights is now we are have emergence of the nasolabial fold. We have a recessed tear trough, thinning of the lips, and marionette lines. And these have been attempted to be addressed with filler augmentation, and we've seen multiple complications, not only in our practice as a tertiary, even a quaternary site, but we hear about this through social media and through patient reports, just through our own experiences in life. Again, volume loss is progressively lost from the 30s into the 50s, and this is what we will talk about shortly. One more key point that I'd like to draw your attention to is that you see here on the photo on the right, we have loss of the eyelid and cheek junction. There is now prominence of the tear trough, there's descent of the eyelid skin beyond and below the orbital rim, atrophy of the mid-face fat compartments, and then the subsequent cutaneous changes that arise from that. And really, it creates hills and valleys. You have hollows and depressions would lead to shadows, and fat volumization and transfer to the face attempts to address these depressions and shadowing. This is a lady that was first depicted here in her 20s, and then later in her, appears to be in her 80s, that was published by Dr. Goldberg, and you'll see that deflation and shadowing along the superior and orbital rim is quite apparent. And finally, volume loss in the area of the deep ligamentous attachments, which arise from the bone to the skin. As oculoplastic surgeons, we pay most attention to the ORL, which is the orbital rim ligament highlighted in blue, the zygomatic ligament highlighted in purple below, and then this brings into attention the septal confluence hollowing, or the double eyelid convexity that we try to efface with the multiple techniques that were described. You'll see the patient here on the left, the same patient on the right, has some fullness of the inferior orbital fat pad, and this might potentially be improved with just fat removal. We see quite nice results with that alone, but he will actually get a more natural and effective rejuvenation if we recognize and also treat the periorbital hollowing. We like to focus on our female patients, but male patients also have similar considerations. And finally, we need to talk about the bags, which are really fat pseudoherniation. You see the gentleman here on the right has a V-shaped deformity, and that arises from the nasojugal groove and the orbital malar groove. And this really is due to volume deficit over the inferior orbital rim. And finally, mid-face descent. Here again, I'd like to highlight in the female patient that she has eyelid fat pseudoherniation, lid cheek interface depression with unmasking of the orbital rim, and mid-face convexity, which is resulted from tissue descent and deflation. But a talk on autologous fat grafting is not complete without also talking about the implications for reconstructive surgery. These are indications that the patient could potentially benefit from autologous fat transfer. We've seen it used in patients with Perry-Romberg syndrome, patients with HIV lipodystrophy, and those with acquired facial scar deformities from reconstructive surgeries in the past or potentially former traumas. We'll now move on to the discussion on the technique of facial fat grafting. This composes of harvesting fat from the donor site. We need to process and prepare it, and then we'll discuss the injection technique and placement of the fat graft. And finally, we'll move into a discussion on the complications. Fat grafting can essentially be taken from anywhere in the body that one has fat. So really almost anywhere. And considerations for the from our standpoint as oculoplastic surgeons is that we have our patients in the supine position. And so that makes it easiest and safest to access the periumbilical area or the inner thigh in females. But we also harvest fat from the outer thigh, the buttocks, the hip. Anywhere where you find fat and the patient is amenable to taking that fat away is ripe for harvest. But again, I do urge you to think when we're thinking from a body standpoint, are we robbing Peter to pay Paul? When you're taking fat from elsewhere and putting it somewhere else, you have to think of the donor side as well. And, you know, we're not harvesting a ton of fat in our cases, but when you're thinking about body rejuvenation, there are complications such as sepsis, linear tracking, bruising, hematomas, infection that all can arise. And I think it's important to not ignore this, this consideration. So fat harvesting technique is depicted here. This was a photo that Dr. Masri and Dr. Azizadeh published in their periorbital fat grafting paper. Here you see the periumbilical approach. They describe the use with telfa to drain the fat and then finally placed in the tuberculin 1 cc syringes. So what I'd like to highlight here is that it is a relatively straightforward technique. It is physically labor intensive when you're starting, but as you go on, you'll realize that it is quite straightforward. And as long as you keep the site sterile and clean, there are minimal complications that can arise from the harvesting component. Dr. Ramesh discussed in the first part of the podcast, on the ASOPers podcast, that many surgeons are doing this now in the office with very mild to moderate sedation, even just oral sedation. And I know you discussed using the MKO melt, which was really interesting. And we're hoping to also integrate into our practice now. The surgical field is prepped and draped. 40 to 50 cc's of local anesthetic are injected with tumescent. In our practice, we use 2% Lido with epi. This is mixed in 100 cc's of normal saline. Some surgeons in our practice also use TXA into the tumescent. An 11 blade is used to perforate the skin, and then the tumescent mixture is injected on a 22 gauge spinal needle to infiltrate both the superficial and the deep fat planes of the umbilicus. We use a 2.1 millimeter multi-port tulip cannula used to harvest the fat, and the harvesting cannula is connected to a 10 millimeter syringe, and manual suction is applied with the constant back and forth motion of the cannula. That's the labor-intensive portion for the oculoplastic fellows here. A 10 ml syringe yields about 5 mLs of injectable and usable fat, and the most important thing to remember here is minimizing the time outside of the body in order to maximize the viability of the fat. And that time has become shorter and shorter in recent practice. At Wills, we use the Pure Graft system. This is a proprietary company that allows us to wash the fat, drain it. Dr. Masri in his paper I mentioned discussed using telfa. Other plastic surgeons that we work with use the centrifuge. We won't really get into the nuances of the different modalities, but just want you to know that there are multiple ways to try and maximize the viability of fat. Here is a case that was done jointly between Dr. Carrasco and Dr. Watson. We harvested, actually we harvested quite more than this, but we ultimately decided to only draw up 12 cc's here of really beautiful yellow fat. There is minimal blood in it, and it was just really, really beautiful fat that had good viability. And I'll show you the results quite far out after surgery. Then the fat is injected. So the harvested fat is injected through a 0.9 millimeter blunt tip cannula. The cannulas vary in size depending on where you want to inject the fat and how small of the fat do you want to use. The entry site is infiltrated with a 1/4 cc of 2% Lido with that bead. An 18 gauge needle, this is similar entry for the cannula to filler. So if you are familiar with injecting filler, this is a little bit different, but you do use the same tract with the 18 gauge needle. With each pass, a small aliquot of fat is injected in a back and forth manner. And Dr. Carrasco and Dr. Watson always remind me that that back and forth manner is the most critical part of the injection portion, because you don't want to have a granuloma or nodular appearance. And you always need to remember to inject deep, which is what we do in our practice. The initial goal of the injection is to build a foundation and then slowly elevate and these discrete topographic depressions. And it's important to stay quite deep at the level of the periosteum. Remember that the skin in the periorbital region is unlike anywhere else in the body. It is very, very thin, and it has little underlying tissue. So this area sometimes can be very unforgiving to someone who is not familiar with the technique of injecting fat rather than filler. This is a picture that I found, and it's a nice way to conceptualize where we transfer the fat. The temporal area that was discussed earlier, the forehead, the tear trough, the buccal fat pad, the upper lip, the nasolabial folds, and the nasojugal area. The entry points are marked here. So they are 3 just near the periorbital region. The first one is superior. It's about 20 millimeters above the central brow. This is to pay attention to the brow area. Very little is typically injected here. And then laterally 10 to 15 millimeters lateral to the canthus. This is a nice area to address superior sulcus hollowing. I'll show you a picture in just a bit where Dr. Carrasco addressed this, but typically we don't want to inject more than 1 to 1.5 cc's. It can induce ptosis in patients that we're trying to also address. And then finally, the lid cheek interface is addressed through the inferior approach, and that is just below the junction of the nasojugal fold and the orbital malar groove. And here we aim to use about 3 cc's of that. This is a photo of a woman who is under general anesthesia. It's a photo that was published by Dr. Masri and Dr. Azizadeh, and it's depicting the injection of harvested fat. I just wanted you to see the setup that they used, and we'll move now on to our post-operative results. The ideal patient is someone who needs addressing of volume loss and perhaps malar flattening. This lady here has really nice volume augmentation of the cheek that we saw at the zygomatic maxillary apex, or the OG point. This is a patient that Dr. Carrasco actually did on a male patient. Male patients tend to be a little bit more hesitant to sign up for this, but you will see here in the video that he has nice effacement of that double eyelid convexity. The malar flattening is slightly now addressed better and has nice volume rejuvenation there. He did not want fat grafted anywhere else in the face, so this is really more to address his concerns in the periorbita. This is a woman that had multiple procedures done. She had upper blepharoplasty, ptosis repair, lower blepharoplasty with also fat transfer. This is a patient, Dr. Carrasco's, and you will see here in the video that she also had effacement of the double convexity of the lower eyelid, and then also volume rejuvenation at that cheek, at the cheek maxillary point. And this is the final photo. Dr. Watson's results are shown here, and again, highlights the same considerations that we've been discussing. I'd like to now move on and talk about complications because I think this is really interesting. And as surgeons, I'm learning that sometimes our satisfaction with our results tends to be perhaps a little bit lower, and we are the most critical of our own results, and we are hesitant to adopt new techniques due to complications that can arise. I will discuss shortly that patients actually tend to be very satisfied with their results, even in the systematic data looking at thousands and thousands of cases, but it's really the surgeons that tend to be hesitant because of the complications. The number one complication that I could garner from the literature is contour irregularities to the eyelid and to the periorbita. But again, because we're taking tissue from elsewhere in the body, scars and pigment disturbances can occur at the entry site, at the area where you take the tissue and the area where you harvest the tissue. Ptosis is something to consider. Depressions, linear tracts, contour irregularities at the donor site, nodules and granulomas. And like filler, it is exceedingly rare with fat grafting to really have intravascular injection and tissue necrosis, but there are a few case reports describing this. And finally, growth of transferred fat in patients who have undergone significant weight gain in a very short period of time. Lumps and bumps are the things that we are trying to get rid of in surgery. So when you create them, or when you have a patient that was referred to you because of an outside procedure, it is a little bit difficult to have them understand that really the only way to get rid of it is another surgery. So surgical excision and revision is required. These are some really nice photos that Dr. Ray Taban published online. These were not cases that were done by him, but there were cases that were referred to him. And you will see here that there are these fat granulomas and lumps and bumps on the lower eyelid and upper eyelid, either from injecting too superficially or injecting too much. And these patients required a second and potentially third surgery to surgically remove the fat from that area. Ptosis is an underestimated complication after autologous fat injection into the eyelid. This is a patient that was shown here from Korea. She underwent more than 3 surgeries to address this. She had cicatricial changes of the upper eyelid, as well as an excessive amount of fat that was grafted into the superior sulcus. If you remember from just a little bit earlier, the maximal amount that you want to inject is somewhere between 1 to maybe 2 cc's, and she had a total of 9 mLs injected into the right upper lid and 7 mLs into the left upper lid. And you can see that despite this is figures A and B are when her first presentation. A is now after the first surgery, and F is after the second surgery, where you see this really prolapsed, scarred fat in the upper eyelid, and G is her final result. So just remember, we can do harm, and less is more, and we like to be more conservative when moving fat into the face. Another really interesting complication that I had read about before and has been described just a couple of times from my knowledge is that fat grafts can grow after weight gain. This lady had a carcinoma of the face that you can see in figure A on the top, which was unrelated to her fat transfer surgery. But because of this, she had multiple serial CT scans. And using that, they were able to show that the fat actually grew. There was diffuse increase in the sub-Q fatty tissues after a 33-pound concomitant weight gain in a 2-year period. And you can see that this led to exophthalmia and dystopia. And you'll see that primarily on the left side in the photo B and C. And finally, facial necrosis after fat grafting and is something we need to be very wary of. This patient was treated with multiple months and rounds of hyperbaric oxygen therapy, and the early cyanosis was the telling sign. She had ischemia of the right nasal wing as soon as she was awakened and sent to the recovery area. That was just about an hour after surgery. The second photo shows delimitation of the area of necrosis in the nasal wing after 1 to 2 rounds of hyperbaric therapy. And the final photo on the right shows the resulting retraction that was 2 millimeters of the right nasal wing, and that was after a year of hyperbaric therapy. In general, patients are extremely satisfied. So this is a study that was a systemic review and meta-analysis that looked at thousands and thousands of cases, specifically 1,568 patients. And it looked at 52 studies reviewing fat grafting. And patient satisfaction is upwards of 90%. And you will see that the surgeon satisfaction is slowly lower. I think we are quite critical of our own results. And you will see that the complication rate, though, is very low. It's less than 5%. Most patients required between 1 to 2 sessions to address all of their needs. And an interesting part of this is that 50 to 60% of injected volume was retained at 1 year. The early studies from the 1990s were showing fat living at about 30% 1 year. So this recent study is showing actually 50 to 60%. So underfilling is a key consideration. So I just like to urge you to consider adding this to your the facial rejuvenation as a adjuvant to the lower eyelid blepharoplasty. If you have any questions, happy to answer them. Thank you.
Okay, well, that's been an interesting morning. I'm going to finish this up with just a few pearls. I'm not going to take too much time here, but we'll chat about a few things that have really, I feel, leveled up my practice, additions to blepharoplasty that really make your results go from A to A plus or what have you. So really, the first question I have when someone comes to me and says, my lids are droopy are, do you have ptosis, dermatoplasis, or brow ptosis? And you can see that most patients usually have a combination of all 3 of those things. So I would say that ptosis surgery is probably one of the most common adjuncts to blepharoplasty in my practice. So a few groundwork terms, MRD1, MRD2, of course. The tarsal show, where the distance from the eyelid crease to the eyelashes, is really what a lot of people perceive, because patients look at that when they compare the symmetry of the lids. They look at that when they are putting makeup on. So it's a really important parameter that we have to specifically assess to know what we have to do for our patients. So ptosis can be divided into a variety of things. Most of your aesthetic patients are going to have involutional ptosis. It is important to make sure that they don't have other reasons for their ptosis, such as a neurologic syndrome, Horner's, or a nerve palsy, mitochondrial disease, etc. One thing that we commonly see in our aesthetic practices, unlike neurologic disease, is hemifacial spasm. So people can have old Bell's palsies, people can have old facelifts that lead to aberrant nerve regeneration, and the synkinesis from that regrown facial nerve can cause ptosis in relation to facial movements, or just ptosis that's intermittent and spastic. So you can see this patient has a right hemifacial spasm, and this patient has a left hemifacial spasm, and they both have droopy lids and ptosis, and the treatment here is toxin, not surgery. So that's probably the most common non-involutional cause of a droopy lid that you might see in your aesthetics practice, and it is important to suss that out so you can treat it appropriately. Now, when I'm deciding if I want to do a ptosis repair or if I want to take skin off the upper lid, between the 2 options, if you do ptosis surgery only in someone who has extra skin, they are still going to be, for the most part, happy with your surgery. So this guy, I lifted his lids, I did posterior approach ptosis repair. His MRD1 is higher. Of course, if you pull up a curtain, the shades bunch up at the top, right? So he has a little bit of pronounced dermatoplasis postoperatively, but it's okay. He's not miserable about it. You can always take some skin out later. If you do blepharoplasty in someone who really needed ptosis repair, it's not good. So this is one of my cases from early fellowship. I did not recognize the ptosis. I took some skin off. He doesn't look good. He looks feminized. So I had to go back later and advance his levator, and he was okay. But, really comparing the 2 not great outcomes, a not great outcome of ptosis surgery is far better than a not great outcome of excessive skin removal. There are a couple ways to do ptosis surgery. This is the posterior approach. Essentially, you tie the aponeurosis from the backside, and then you trim it using, a special clamp, or there's a variety of ways to do this. And here, I've advanced that aponeurosis posteriorly. You can also go from the front. You can peel up that pre-aponeurotic fat pad, look at the aponeurosis, and then touch it where you want. So there's options as far as ptosis repair. But I really feel like it's the best adjunct to blepharoplasty. So people who don't complain about ptosis, who don't know what the word ptosis means, I still do ptosis repair, and I don't make a big deal about it. I don't say I'm going to do this and blepharoplasty. I just do it because it's important for the overall aesthetic result. So this woman, I did her upper and lower lids. I did a baby ptosis repair, and having that extra millimeter half of space between her lid margin and her pupil really brightens the eyes. People who have blue eyes notice that their eyes appear bluer because their eyes are not shaded by their lashes. So it really makes a big difference. It's that subtle touch that really makes the upper lid blepharoplasty that much better. One thing that can happen in blepharoplasty, especially if people are taking out a little bit of skin, septum, fat, is that if you don't always attach the crease, sometimes it doesn't form. So this lady came to me from another surgeon. On the right side, that aponeurotic attachment had not reformed appropriately. She thought she was still droopy and she had extra skin. But what actually happened is that her crease, quote unquote, slipped. So I just did ptosis surgery. I didn't remove any skin. I reformed the crease, and she has that high, sharp crease that she wanted. So ptosis surgery is also a great way to address revisional blepharoplasty concerns. Brow ptosis. So we discussed before, any skin or hooding past the lateral canthus really means there's some amount of brow ptosis. And I love showing patients this picture because this is a woman that I did upper and lower on, and she did not want a brow lift. And she had a great right side, and she had a droopy left side. And it really helps people to understand what happens when you do blepharoplasty and ptosis repair in someone who also needs a brow lift. And she was happy. She didn't end up doing the brow lift, but you can see that the lateral hooding really doesn't improve unless you lift the brow from above. You can't get rid of this line at the crow's foot completely unless you do a brow lift. And then the tarsal platform, that tarsus, tapers off to a point. You don't get an even crease height all the way out to the very last eyelash unless you do something to the brow. And women in particular notice that because they want to apply mascara out to the very last eyelash and then wing it up. So if you don't give them that tarsal platform show all the way out to the very last eyelash, they notice it and they're not happy with their blepharoplasty. And just doing more skin removal is not going to solve that problem. You really have to look at the global aesthetic. So in men with a big, heavy crease, you can just cut some skin out and stitch it together, and they look great. So these are two patients who had ptosis repair, upper bleph, and a direct brow lift. And you can hide that in their bushy eyebrow hairs or their deep forehead rhytids, especially if they're Fitzpatrick 1 or 2 skin type, and they look nice. Women typically want an endoscopic brow lift, so we make a couple hairline incisions. You take the camera and you go down, and you can see the ligaments that keep our temple attached to our forehead. So the temporal ligaments, the arcus marginalis at the superior orbital rim, all of these you release, and it's really a brow recontouring surgery. How much you release it on one side doesn't have to be the same release on the other side. You can shape the brow, you can elevate the brows different heights. So this is really a nice way of addressing the brow that leaves very minimal, downtime or, skin incisions. So again, blepharoplasty with a brow lift helps you address the lateral hooding so you can clear up the crow's feet area by lifting it from above and below. You can give yourself an even tarsal platform so the crease height is maintained across the whole lid. You can get rid of this line in particular, which drives a lot of people crazy. And then you can also treat the lids by just doing brow lift. So this patient, I did not touch her eyelids. I only did a brow lift. This is 2 weeks after surgery, and you can see the glabellar fullness and the overall lid crease are much better just from lifting the brow. And in particular, patients who have asymmetric lids. So she came to me and said, can you do an upper bleph and do more on the right side? I only did a brow lift, more on the right than the left. I didn't touch her lids at all. You can see you get improved symmetry in the lids in someone who really comes to you because they're bothered by their eyelids. So the eyebrow surgery is not for the brows, it's for the lids. So it's a really important adjunct for people who have that kind of asymmetry or hooding that they may not know that they're bothered by, but you have to figure it out and treat them appropriately. And then this is the lady with the most asymmetric brows that I've ever seen. So I lifted the left side and I did Botox for the right side, and she's happy. So one thing I'll say about brow lifting, people, when you mention the word brow lift, patients always ask, I don't want to look surprised, right? That's the first thing that they say. So I love showing this picture because this is a woman who I did a brow lift and a bluff on, and she was very particular. She said, this is my, a photo from when I was in high school. I always had these sad little puppy dog eyebrows. I don't want that shape to change. The modern aesthetic is to have the tail of the brow higher than the inner part of the brow. And she specifically said she didn't want that. So the endobrow is a customizable procedure where you can shape it how you want. You lift the tissue, get it out of the canthus, but we were able to maintain that particular shape of her eyebrow by lifting the brow as a unit rather than focusing more on the lateral brow, which is what I usually do. So again, listen to your patients. You want to change their facial shape because brows are really an expressive feature, and it really can change how they look if you don't ask them beforehand. And then we'll get to the skin. The simplest case, take a little skin off, it's fine. With Asians, you want to be a little careful. You might want to take less skin. You might want to do ptosis surgery. You might want to address the epicanthal fold at the same time. But resurfacing. So we talked about chemical peels. I'll talk a little bit about lasers. This is crepe paper. If you stretch out crepe paper and cut it, it's still going to be crepe paper, right? So if you make the skin thicker, if you give it more collagen, if you resurface it with an energy or a peel-based, treatment, you can get an improved texture and quality and pigment of the skin. So the deeper the peel or the laser goes, the more risky it is. So darker skin types, you have to do light treatments, fractional treatments, multiple treatments. With people who are Fitzpatrick 1 or 2, you can go deep, you can blast them, do it in one session, and they look great. So patients who had upper and lower bleph, this was TCA. This is, me doing the erbium laser. You can see how the skin really shrink wraps, and it really gives you a great result. You can see that you erase those actinic lines. There's no way to cut these lines out. You have to resurface the skin to get this out of the skin. And, some people, this woman came to me, she'd had lower bleph before, and I revised it. I did some fat, but I think the laser is really what made the most difference. I think, that finishing touch on the skin is really what made her the most happy out of all the things that I did. One of the little tricks you can do with TCA is if you put it on the upper lid, a little bit, not high concentration, you can actually get the lashes to evert a little bit. So that's something that every once in a while I employ. And then, I'm not going to go over Dr. Shbaklo's talk again, but global volume loss is an issue in patients with droopy lids. So if you take out fat, I think you have to put some fat back somewhere. So I grafted fat to her superior sulcus, and after I did the lower bleph, I added some to her midface, and you can add it globally. So I think there's a lot of, reasons to do fat grafting, even if you lift someone. So I lifted her brows, I lifted her lids, I lifted her face. She still benefited from a little bit of fat in a few of these areas. So I think if you step back and look at the person as a whole, these are the tips and tricks that really take you from what I felt I was getting mediocre results to getting results that patients were really happy with. So thanks for listening to me talk about one of my favorite subjects.
Great talk, Deepak. I think I'm a big proponent of brow surgery as well. And it just feels like, most patients can benefit from it. The trick is convincing the patients that they need that, because most patients, as you know, just want to get their eyelids done. So I think, what did you say that when you lift the curtain, it bunches, what were you saying? You were saying something.
Yeah.
That was for the toes.
For the
You
toes,
said
but
something about the brow.
the point of the brow surgery is to give you a better lid surgery.
Yeah.
It's not about the brow.
It's a nice thing to say.
Yeah.
Can I ask a question of the faculty?
Yes.
I have two, actually. I'm going to drop some names, but I'm old enough to do that. The first is that I knew, to paraphrase a famous political statement, I knew Byron Smith, and there will never be another Byron Smith. He was amazing. But he was also cavalier in terms of his, being sued 3 times a year. Being sued as a physician is probably the most traumatic thing we have to deal with. God bless me, I never was sued, but I was an expert witness. 10% unhappy rate with fat transfer. That's pretty high compared to the other things we do in ophthalmology. And these are the very time-intensive patients that are going to be there for a while. How do you select? How do you, the three of you, I mean, how do you select who you do, actually the four of you, to avoid that trauma of the unhappy patient?
Well, I carefully select for that transfer. I don't do it as a standard, like some surgeons do it standard for their blepharoplasty. I think, Deepak, you can talk to that. So I guess I can talk more about, selecting those patients. I do a lot of lower lid blepharoplasty and a select few, I discuss that. I do think it adds a layer of complexity. Although I think patients look wonderful, and I believe you'll do great. And this is good for your face and, your lower lids and everything, but some patients don't want to take that risk. So I just talk about, that it is a second site, that we take fat, the risk of infection, very unlikely. I tend to underfill. And I think there was a time where people suggested a 30% overfill because some of it dies, like 50%, dies. But I think it's much harder to correct if you overfill. So underfill is probably the best thing to do. So, I said, I won't stuff your face and it will just be, more smooth, but that's up to you. I just mentioned it. Is it a possibility? Is it a possible add-on? I don't know how you talk to patients.
Yeah, I don't make it optional. I do it on pretty much every lower blepharoplasty patient, except for young premenopausal women who are runners, who have really, really thin face, not a lot of good fat, because most of that fat is not going to survive. But apart from that, I do it on 99% of my blepharoplasty. I don't tell them, this is something that I'm going to do. I tell them I'm going to take out some fat. I'm going to add a little bit of fat back to smooth things around. Because I think that, to use your analogy, transposition really only works if Paul is sitting right next to Peter, right? So most people need volume in the lateral, zygomatic aspect. They need volume in their temple, in their midface. So these are other places where they need volume. And to get that overall zoomed out result, instead of just focusing on the tear trough itself, I think you have to add volume back. Now, complications wise, I think in the past, fat transfer has really been only around since the mid-90s. We weren't gentle with the fat, less of it survived, so we had to do more of it. So people were injecting 80 to 100 cc's or more in a face. Now, if I'm doing a face, I inject 20 to 30 cc's because I am gentler about the fat. I know now from data and volumetric studies how much of that fat is going to survive, and I know what the forgiving areas are. So the techniques now are much better than how they used to be. And a lot of that meta-analysis data may have included some of those older patients who, unfortunately, we had to learn by doing.
Yeah, I wanted just to reiterate what Dr. Ramesh was saying about that paper and the meta-analysis. It took into account 52 papers over a vast time frame. And so they didn't really, you really couldn't control from that aspect. But I think in aesthetic surgery, that's what I'm quickly learning is patient selection is really one of the greatest arts to what we do. And it's just selecting with any surgery that we do, either from a functional or even more so from an aesthetic point, because what we're doing is elective. What really was interesting to me was that the surgeon satisfaction was slightly less. And I think that for people who are learning to adopt this technique, that's something to take into account in the early stages.
And a question from the online audience, any tips to prevent central retinal artery embolization with fat transfer?
I think the main thing is you want to use a cannula, not a needle. So nanofat can be injected with a needle, but I still use a cannula for that. Microfat or the typical structural autologous fat can only be injected with a cannula, but you have to make sure you use a 20 gauge or larger cannula. Never inject a bolus anywhere. Always inject when you withdraw. Similar principles to doing filler.
Excellent. Any other questions from our audience? Well, thank you all for coming here in person and virtually. And it's been an excellent symposium. And don't forget to register, do the QR code for your CME. Thank you all.